animal experiments that is being carried out at our institution, and not only at our institution, globally, wherever we are doing, we need to have a good laboratory practice. Then only the quality of the results or the interpretation or the outcome of the research will take us a long way, and which will have a community impact on the research that we are going to take over. So with this brief, I wish to introduce Dr. Barnali Das. Madam is a consultant laboratory medicine from Kokilaben Dhirubhai Ambani Hospital, a senior most person in the research as well as in the good laboratory practice. Madam is going to speak on the instrumentation quality, operational quality, as well as the performance quality of the instrument. These are some of the basic steps to ensure the good clinical laboratory practices, and which will be followed by identifying the errors which forms the basis of the good laboratory practice, which will be the resource person will be the renowned pathologist, Dr. Sujay Prasad, which will be followed by ethical considerations in good laboratory practice by a renowned microbiologist from Ranganaya Medical College, Dr. Katar Srinivas Rao. To say a few things about Dr. Barnali Das ma'am. Ma'am is the consultant laboratory medicine, Kokilaben Dhirubhai Ambani Hospital, Medical Research Institute, Mumbai. Madam is the executive member, scientific division, International Federation of Clinical Chemistry and Laboratory Medicine, IFCC. She is the chair, American Association of Clinical Chemistry, Indian section. Madam is the NABL assessor and College of American Pathologist inspector. Madam, to our credit, is an editorial board member of Practical Laboratory Medicine, a renowned journal with a good impact factor, and in an indexed journal, Elsevier, and editor-in-chief for AKI, special issue, PLM. Madam has got 3 Oration Awards and 5 international and 8 national awards from College of American of Pathologists. This itself shows Madam's quality with respect to the research and patient care, which is an outstanding speaker award which she was conferred with. And Madam is the recipient of 2021 the White Knight Award, Healthcare Heroes of India by Metropolis Healthcare and Custodians of Humanity Award 2021. And Madam has worked a lot for the COVID task force. Her biography has been featured in the book named And So Can You, where successful doctors had shared their inspiring stories. She has many research publications in international and national journals, such as the Clinical Chemistry, a renowned journal in the field by the peer group, European Thyroid Journal, Clinical Biochemistry, Indian Heart Journal, IJCB and IJMB. So I welcome you to this good clinical laboratory practice, ma'am. And ma'am, thank you. Ma'am's talk will be followed by Dr. Sujay Prasad. And sir is a renowned pathologist across the globe. And sir is the creative force behind the new innovations. Presently, sir is the director Anand Diagnostic Laboratory, which is an associate of the Newberg Diagnostics, Bangalore, which is based at Bangalore, but its tentacles has been spread across the globe. And sir's technology initiatives and business process has improved Anand Diagnostics and has placed it globally. He has been instrumental in expanding the service capability of Anand Lab from facility expansion to acquisition of state-of-the-art equipment. Sir has got zero tolerance attitude to the errors, which personally we have seen during the various meetings with sir. He has designed innovative methods that focus on minimizing errors across all operating processes. And he is a certified lead assessor for NABL ISO 15189 accreditation process and has conducted many technical assessments overseas, and he has given his valuable inputs when our lab went for NABL assessment. And sir is one of the guiding force for our institution with respect to the internal quality assurance cell. Sir has obtained his MD in pathology from Mumbai University and joined Anand Diagnostic Laboratory in 1995. His experience with respect to hematology, flow cytometry, clinical chemistry, and electrophoresis, mass spectrometry in laboratory medicine. There are no words to explain about his experience and his contribution towards these things. And sir has contributed a lot with respect to the artificial intelligence in the laboratory medicine. He has delivered many guest lectures on quality in laboratory medicine, hemoglobin variants and their detection, mass spectrometry in immunosuppressants and vitamin D errors in laboratory medicine, cost of cutting cost in laboratory medicine. And his talk really will enthrall us with respect to the workshop on good laboratory practice. And I wish to say proudly about Dr. Katar Srinivas Rao. Recently, I had met him when sir had visited our institution to conduct the post-graduation medical examination. So there I could see the sir's quality and his contribution to the quality aspects of the research and various other things. Dr. Katar Srinivas Rao has graduated MBBS in 1989 and completed his post-graduation in MD Microbiology in 1994. He is a distinguished luminary who has undergone training in WHO quality control in HIV testing, CRO-JE network lab. Sir has got many renowned and reputed memberships in the Indian Immunology Society, International AIDS Society, Indian Association of Medical Microbiologists. Sir is an NMC assessor for both undergraduate as well as postgraduate. He is the coordinator for infection prevention and control practices in Andhra Pradesh. Sir is Madam Dr. Radharani Srinivas Rao is MD DM in an endocrinologist, a renowned endocrinologist. Sir is blessed with two daughters, and both of them have completed their medical education and they are aspiring for the postgraduate. So with this brief introduction of the renowned three speakers who are globally reputed, I welcome you all for today's good laboratory practice. So with this, I wish a very good morning to one and all who have assembled here. And I welcome once again all the resource persons as well as the participants. Truly, at the end of the session, many of us will understand what we did not know all these days and how we were carrying out the research. Thank you. Over to Dr. Ashwini.
Thank you, sir, for the introductory remarks. We shall move on to our first session now by Dr. Barnali Das, ma'am, on basic steps to ensure good clinical laboratory practice. Over to you, ma'am.
Thank you, sir, for the kind introduction, and thank you, SDU AHER, Sri Debraj URS Medical College, for inviting me and giving me this opportunity. Thanks to the Dean Sir, Principal Sir, Vice Principal Sir, Dr. Shashidhar K. for kind invitation, and R&D team and organizing team, and all the faculty members of biochemistry, immunology, and pathology, microbiology. So I really am honored to participate in this good laboratory practice workshop. And I am honored to be present with the co-speakers who are really very renowned in the field of laboratory medicine. So now I'll share my slide. You can see my slide.
Just a minute, ma'am. No, ma'am. Oh, now we can see the slides.
You can see it.
Yes, ma'am.
So today my talk, actually it's echoing. So I think if it's muted from your, hello?
Yes, ma'am.
Can you hear me properly?
Yes, ma'am.
You're clear, ma'am.
Yes, thank you so much. So now I will start with my talk. So my talk today is IQ or QPQ of instrument or equipment this is the basic steps to ensure good clinical laboratory practice. Because many times when like now next week we have College of American Pathologist inspection, and next month we have NABL assessment. So when we were I even after I think this is the 13th year of our CAP inspection and NABL assessment. So even then I felt so many when we checked the IQ, QPQ of all the equipments, many POC equipments when we checked which are like moderate complexity. So I find the deficiency even in my own setup, that deficiency or non-compliances in documentations of IQ, QPQ. So therefore, when Dr. Shashidhar sir asked me for taking this GCLP workshop, I thought let me try to talk on IQ, QPQ, and so let's see why this is important. Because we here the R&D team is there, and the biochemistry, then pathology and microbiology team is there. So for us diagnosticians or academicians, every blood samples, whoever present in the lab, every, or for research also, every blood sample tells us a story. So this is, before starting my talk, this is my painting to acknowledge all our efforts during the COVID time, even after pre-COVID. Also, we were always the diagnosticians or the pathologist, biochemist, or microbiologist. Always we used to feel that in any hospital or in academics, always we used to be behind curtain because the patient used to see the clinicians. But when during the COVID, we realized how the important role of lab physician in any kind of setup. So we may be doing the test in autoanalyzer or in microbiology or molecular biology, they are testing by our RT-PCR or R&D team. They are doing sequencing, and in histopathology, they are, or hematology, they are seeing the slides under microscope. So maybe we are doing a lot of work in different kind of equipment, and and the clinicians based on the evidence-based medicine thing, and based on our report, they are taking, they are diagnosing, treating the patients and monitoring the patients. So if you see, yeah, of course the patients see the clinicians, but if you see this extended hand, this extended hand is ours. All I here acknowledge all the diagnosticians, all the academicians, all the faculty from all the department of the biochemistry, pathology and microbiology, because our efforts are really enormous. So GCLP guidelines, so all laboratory engaged in testing of biological sample need to establish the confidence in the quality and reliability of the result of this test. So whatever test we are reporting, we need to, like for patients, we should be reliable, and the quality should be established. So this expectation are fulfilled by following the good laboratory practice. So this is the introduction slide, like as this is the GCLP workshop. This is ICMR guidelines 2021, according to that. And this set the principles that define a quality system concerned with the organizational process and the conditions under which laboratory studies are planned, performed, monitored, recorded, archived, and reported. So this all like planned, performed, monitored, recorded, and archived. Many times you will see everything is very good and all the processes followed. But when you go to archival, you will see maybe the expired or the previous instrument which discontinued in any lab that has not archived properly. So, and it should be reported. So anything, if it is not reported or if not documented, so it's not done. So it is intended to promote the quality test data. And similarly, for relying on conclusions drawn from the clinical data, there is a need to follow good clinical practices, which are standards for the design, conduct, performance, monitoring, auditing, recording, analyzing, and reporting, and reported results should be credible and accurate. Either it may be clinical trials in R&D, or maybe any students doing any research. So this all, or the lab, the diagnostic lab like us. So this, all the processes, any of the thing, any of the laboratory process, or any of the like academic process where the tests are done for research purpose or for diagnostic purpose or for monitoring purpose. So this, all the steps should be done properly. So each lab should prepare a list of equipment. What is equipment required for functioning of the lab, depending on the types of tests performed. Equipment includes hardware, software of instruments, and measuring systems and lab information system. So many times we do IQ, OQ, PQ, and do performance qualification of our instruments or equipment. But we forget if there is any digital transformation platform, laboratory information systems many times, or maybe we are doing some for some of the practices, we are taking the help of AI, artificial intelligence, or machine learning or deep learning. So we forget to validate or verify that. So this equipment includes all of those like hardware and software of instrument and measuring system. So the lab equipment should be of adequate capacity to meet the workload requirement, and equipment should be suitably located in the lab so as to allow accessibility and sequential utilization, thus minimizing the need for frequent movement of manpower, specimens, and reagent. This is the definition by ICMR 2021. Can you please mute? The following should be ensured. Equipment should be selected to meet the requirements of lab in terms of design and capacity. So there we talk about IQ, OQ, PQ, but many times we forget about the design qualification or DQ. So here I will actually share some slides on DQ, because suppose one lab is going for total lab automations and they are trying AMS and CDS, clinical decision support. So then design qualifications. So what is the current lab design and how they want to design the process based on lean process, or maybe based on their requirements. So DQ is also very important. So IQ is installation qualification, operational qualification is OQ, and performance qualification is PQ. So all equipment should undergo calibration and verification. So conducting or performing the calibration process involves applying a standard value to the lab instrument and observing how it behaves. Calibration frequency should be as defined by the manufacturer or as per the norm. So in case examination systems such as automated analyzers, the calibration should be done by the manufacturer, or many times during the PM, they do preventive maintenance, they do the calibration. And all the automated examination systems such as cell counters, clinical biochemistry, autoanalyzers, automated coagulometers, ELISA readers, everything in the lab shall be calibrated at regular intervals as per SOP. And raw data generated during the calibration should be maintained as a record. So like yesterday, I was going with the CAP checklist. Though I saw, like when we were checking the calibration records, I saw we have all the calibration certificate, and many of the, like, instrument or IVD, they give one documentation. So nowadays many of the IVD manufacturers don't give calibration certificate, they give documentations that during the preventive maintenance calibration has been done, and as per the norms, they give one letter. So, but when I was checking one instrument, the raw data were not available. So it has done long back, maybe 10 years back, but I can't find the raw data, because that time we must have sold, but it was not archived properly. So these are the, like, deficiencies, common deficiencies we see in, like, in terms of calibration. And so because of that, whenever calibration done by the lab or done by the IVD people or the engineer, so then the raw data should be maintained in that calibration file. And the preventive maintenance program for all equipment should be created and implemented, and this can be done by preparing a checklist format calendar for the equipment maintenance as applicable. Then if there is a checklist or there is a calendar, so we know, like, when the PM is due, so you can keep in, like, on display when there is an instrument level. So you can keep that display, that PM due maybe June 26 or something like that. So then all the, like, whoever is working in that lab, even the junior most technical officer, they know, like, when the PM due for this and this instrument. So now, like, why these all are important, so this is the cartoon. So let me share with you this story. So this, you must have all attended this, like, WhatsApp, in multiple WhatsApp group. So this is, I think, during the second wave of COVID last year. You must have heard this, that one patient interleukin 6 in one lab in the morning, it was 3000, and then when they rechecked, it was 126 picogram per ml. So patient got admitted because during the COVID time, the WhatsApp like doctors or battery of tests used to perform with any patients, even the fever for 1 days, like low grade fever, they used to do the battery of test based on, like, whatever documents they used to, this lab test should be done by WhatsApp, they used to get. So this patient went for like that. So they, in home collection, he has done the interleukin 6 for his mother. And then they realized, the clinician asked, like, immediately to get admitted, because it's 3000 picogram per ml. So when this patient was getting admitted, so they have taken the blood sample for CRP and other tests. And then that time, this interleukin 6, along with our RT-PCR report, came positive, and interleukin 6 at that time was 6 picogram per ml. Within few hours, interleukin 6, 3000 to 6 picogram per ml. So then the clinician is thinking, or intensivist is thinking, what lab result to believe, or the infectious disease specialist, and which one is the good lab. These all three are good lab, but which one to believe? So because of that, our role as a lab physician, our role as a diagnosticians are very important. If you see here in this cartoon, the patients are coming with burden of disease, and then inside our lab, we use our intelligence, we use our discipline and creativity. This all three are very important. Why? Because many times the intelligence is important, creativity is important, discipline is important, because when it comes to design qualification, when it comes to maybe like reference interval, 3 days back I got a call from very famous pathologist in Mumbai, that what is the reference interval you give in your lab for thyroid TSH in pregnant female. So then then I realized, I asked what you are giving. He told me that I am giving from the TEAS textbook of clinical chemistry. So then I said that like Indian Thyroid Associations, they mentioned totally different values of TSH in pregnancy. And so the gynecologists who are practicing, who are the clinicians, so they are using the TSH pregnant female reference interval totally different. So this all mistake I have also done in my lab live. So this is like, because of that, these three are very important. And if you recognize this person, this can be you or me, as a College of a Medical Pathologist inspector or NABL assessor. We do sample audit for 1 day, or for NABL we do for assessment for 2 days. And based on our sample audit or observation, we say, oh, this lab seems to be very good. There is very few deficiencies or non-compliance, or this lab has so many deficiencies or non-compliance. So it's not that deficiencies or non-compliance define us, but yes, if we do systematically, like IQ, OQ, PQ, and systematically all the checklist, what is there in the good laboratory practice. I was going to good laboratory practice and I printed yesterday the 2021 for my lab staff. So if we go through the good laboratory practice guidelines, if we go through the different checklist, and if we customize the checklist for our own setup, any kind of setup, maybe hospital, maybe academic institute, or maybe reference lab, so that good laboratory practice, actually in the long run we are benefited. So this is our lab system. And then comes the role of the clinicians. When patients are going out with a report, they go to the clinicians. So either you are getting called, oh, Barnali, what creatinine value you have reported for this patient. This is not at all, patient is on dialysis, and you have given the value which is like patient's last value was 3.2, and now today you have given the value 1.4. So this is your report is not correct. So actually, based on, or maybe your clinicians are so satisfied, they will go to different places, and during whenever they meet anyone, they say, oh, this their lab is so good that we get so precise and accurate results. So this is our lab system. And so, as I said, this is one case of one 56-year-old physician. So why I am starting with this case study to tell you about the story, like how lab people, or how the diagnosticians, or how the pathology, biochemistry and microbiology, how they take important decision, and what is the role of ours, that how can we can change everything in the in our healthcare and hospital sector for transformation. So this is one 56-year-old physician, history of fever, cold since 6 days, associated with cough with expectorant, history of severe body ache, decreased appetite, mild hypertensive, history of contact suspected. This was February 2020. So just COVID-19 started February and March beginning. So, and patient was mild hypertensive, and history of similar complaints in close family. So patient started, because he was physician, so started hydroxychloroquine on his own on day 3, and day 6 our RT-PCR was positive. So see the markers: liver function test deranged, triglyceride increase, LDH increase, ferritin increase, D-dimer increase, CPK increase, blood gas derange, then hemoglobin decrease, neutrophil lymphocyte ratio deranged. So CRP increase, procalcitonin is this is mainly shows viremia along with the secondary bacterial infection. So procalcitonin, usually during the COVID we saw not much increase, it's a minimum increase. So here in this patient it was normal. And IL-6, I will tell you the story of IL-6. Actually this whole case is because of IL-6, was 126 picogram per ml. So this 56-year-old physician, initial treatment, they started paracetamol, ceftriaxone, hydroxychloroquine, but there is persistent high fever, day 9, increasing CRP and ferritin. They started lopanavir, ritonavir, single dose, but they have to stop it because high QTC interval. The fever is increasing, patient desaturating, and chest X-ray, bilateral infiltrate, a CT scan showed ground glass opacity. So cytokine storm is raging, high fever, increased D-dimer and ferritin. So 2020, around February end and March beginning, I got a call Sunday morning. I got a call from our intensivist, then from our infectious disease specialist, that Barnali, we want to try tocilizumab because the patient is deteriorating. So we want to try tocilizumab because that time tocilizumab is not a very common drug. And for that, we need to do interleukin 6, and we need that report in few hours time. So we were not doing interleukin 6 that time, and that time interleukin 6 was not a very common test. And but we have, like, long back, we have, when interleukin 6 was marketed, we have done some pilot study as a research project, but we discontinued because there was not much workload for that, and not at all, not a single workload for that, so we discontinued. So that Sunday morning, that for tocilizumab of one of the physician colleague from another hospital, I need to do interleukin 6, and I have to give the report in few hours time. So what to do? Then I checked all over India, then checked in Mumbai. So nobody was doing IL-6. One lab, reference lab, was doing that also on Thursday. Sunday morning, I can't wait till Thursday for doing interleukin 6. And then I asked the, IVD people that you open the warehouse and supply me the kit of interleukin 6. So then they opened the warehouse, which is outskirts of Mumbai. They supplied us the kit in, I think, 1.5 hours. We rushed to the hospital, the validation, because that time was lockdown and staggering duties. The senior technical people rushed to the hospital. So we have to do interleukin 6 validation, and validation in few hours. And we have to report the interleukin 6 in few hours time. How can it be possible? Because our minimum, the validation protocol is of 5 days minimum. So the verification of validation, we need a minimum 5 days. So how to do that? Then I called College of American Pathologists. I called CLSI, and AACC, like the members who are there in the CLSI committee, that during the pandemic situations, how can I verify interleukin 6 in my own lab, because this is a new test. So then they suggested you do the reproducibility, you check 20 times, and if reproducibility, you feel that verification value and SR and sigma R is more than the manufacturer claims, then you can report it. So this was emergency verification and validation. So I remember in 3 or 4 hours, we have reported for that patient. Nowadays, interleukin 6 base level and all are not required for monitoring of tocilizumab treatment. But that time, clinicians evolved, diagnosticians evolved, every one of us have evolved during this COVID pandemic. So they started tocilizumab 400 milligram, repeat dose after 1 day, but fever was persistent, inflammatory marker increased, oxygen requirement, the patient was desaturating even with the tocilizumab. Then they started methylprednisolone and 30 milligram twice daily for 3 days. Then fever subsided, decreased CRP, no oxygen requirement, patient was discharged. So now, if this is a simple story of any lab, it may be your lab, my lab. So this has happened to each and every lab. How my friends in Leh Ladakh, they for NABL assessment, they have prepared RT-PCR. So that's actually this is the total transformation of the system during this pandemic time or COVID time. So why this story I have told, because you saw the variation in the lab results, like 3006 in the first patient, and second patient I described, like during the emergency situation, how can we verify the test or how can I validate that test. Both this showed, like, how lab plays very significant role. So outline of my today's talk is installation qualification, that is IQ, understanding the IQ, OQ, PQ for IVD device, tangible and intangible aspects related to installation, requirement for IQ. Then I will talk about the design qualification. Then third thing is operational qualification, and the final thing is performance qualification, where we lab people take very important role. IQ, OQ can be done by the instrument people, and the engineer or IVD sector, but PQ is our responsibility. Along with the IVD people, we have to take part in PQ and design qualification. Let's see how. So IQ, OQ, PQ protocols are methods for demonstrating that equipment being used or installed we will offer a high degree of quality assurance. The goal is process validation, is to deliver a stable IVD that offers consistent performance. Variation should be minimal and predictable. So process validation plan will provide the framework for executing three important phases of validation process, like IQ. IQ should answer the question, is everything installed correctly? OQ should answer the question, is everything operating correctly? Are operating limits understood? This is very important because many times maybe system engineers who comes to do IQ, OQ, PQ, they have no clue, they just use the format which is given to his senior or her senior. So based on that, they just give, okay, IQ, OQ, PQ of this so and so instrument done. But have they understood that is like our operating limits are clearly defined, and performance qualification is our job. Did it produce the correct result? Is the process stable and capable? So if we see the IQ, OQ, PQ process, like if whenever you are starting new lab or a new team, any process, this may be R&D process, this may be any lab process, you are going for the total lab or automation. So form the validation team, plan, approach, and define the parameters, identify and describe the process, then create the validation master plan and specify the process parameters and outputs, select methods and tools, then perform the design qualification, create protocols, then perform IQ, perform OQ, and perform the PQ. Then you prepare the final report and determine the process controls, monitor and control the process, and revalidate as appropriate. So this is the whole IQ, OQ, PQ process. Why this, determination of process controls, monitor and revalidation or verification important? Like I will, if I get time, I will discuss about the process of Sigma metrics along with IQ, OQ, PQ, how it important for design qualifications. So in that, there is a DMAC, like define, measure, analyze, improve, and control. So monitoring, when you have done the IQ, OQ, PQ, this monitoring is very much important for us. So this is the total process, and IQ verifies that instrument being qualified and have been installed and configured according to the manufacturer's specifications or installation checklist. It is documented that collection of activities necessary to establish that an instrument is delivered as designed and specified, properly installed in manufacturer specified environment. So what we need for that: location of installation and necessary floor space. So IQ should have this kind, this documentation too. Documentation, any and all computer controlled instrumentation, gathering all manuals and certifications, properly unpacking and cross-checking of the instruments, examining instruments and components for damage, ensuring correct power supply, documentation, firmware versions and serial numbers, environment and operating conditions, checking software system installation and accessibility, recording calibration and validation date of tools used for IQ, and verifying all the connections. So this all should be there in the installation qualification report. IQ verifies that an instrument being qualified as well as its subsystem and any ancillary systems so have been installed and configured according to the manufacturer's specification or installation checklist. FDA's IQ definition offers useful statement of the overall goal, documenting that the system has the necessary prerequisite conditions to function as expected. The basic idea of IQ is to ensure that everything is installed properly. So along with the current good manufacturing practice requirements relevant to IQ, the methodology used for IQ must be documented thoroughly in the validation master plan. So at various stages during IQ, you need to review, check, report, and authorize the protocol. You need to check the specification and the acceptance criteria. So IQ touches many tangible and intangible aspects related to installation, including components and equipment, software, and on the standard operating procedure for your software, calibration and testing, installation, software and system testing, records, electrical testing, then signals and alarms, revalidation, facility conditions, and documentation. So there should be an SOP, there should be a checklist and some other documented process that defines the standard installation procedure for each type of system or deliverable being installed. This is required for any equipment used in lab. IQ verifies and documents key aspects of an installation meet approved requirements. And these requirements may come from design specifications, system specifications, manufacturer recommendations, and data sheets. So this is one example of one IVD manufacturers, what should be there in the IQ reports, like general information, system information, then installation information. Then if the checklist should mention operator's manual available or not, that they should specify environmental parameters, instrument deliver undamaged and complete, transport locking successfully removed, all connections correctly installed, instrument positions according to installation manual, instrument boot process successfully according to the specification, mechanical adjustment, auxiliary components positions, instrument installation check, host communication settings change, or it is checked or not, and then the IQ should mention if there is any deviation. So this is the deviation report. If you observe any deviations, what is the corrective action, what is the investigation, what is the corrective action and preventive action taken. So this is now coming to the design qualification. In addition to IQ, we should perform design qualification. It may be old lab, we don't need so much of design qualification, but it's always better, like, one instrument is coming to our lab, so redesign the process. Redesign the process according to the lean process so that less movement, less rework is done, and the thing should be in the lean flow. And DQ proves that the design or selection of the equipment meets your requirement, and it documents that the equipment consideration were included in design controls and the equipment requirements identified prior to purchasing or reagent rental. So think of DQ as a bridge, from design to installation. And this is important element in planning product realization and resources. I know the design qualification, why I have actually mentioning this slide, because during our lab, when we are going for the total lab automation process, so we checked everything like current clinical chemistry, immunoassay, how many square foot, hematology, then central receiving. So if you see currently, like from here to here, the movement is required. The proposed is central receiving and then clinical chemistry, immunoassay, hematology lab. And with the proposed version, this is like around 14.4% reduction in the square feet area, and the simplification of the process, 74% reduction in sample touches and batching. Then real estate saving 341 square feet is very much important for Mumbai, and future proof like around 2 times capacity test per hour per meter square, and sample draws more than 40% reduction in tubes drawn per patient, because there are many it's the process is like going from here to here. So for microbiology, triple H testing, there is separate tube. From biochemistry and immunoassay, there are separate tubes. So because of that, sample draws also is tube reduction also is there with proper design qualification. Then maintenance, 16 days man hours saved per annum, and staff only maximum 5 full-term staff required to run the core lab, only the core lab, not the other. So now we have around 16 and 5 only for the core lab functioning, from 16 to 5. So this is so they can proper manpower utilization. Then operational qualifications, its purpose is to determine that the equipment performance is consistent with the user requirement specification within the manufacturer specified operating ranges. So for that, we need, if you have performed IQ and checked all aspects of installation, the next step is OQ. And this means identifying and inspecting equipment features that can impact final quality. So during OQ, all items in the test plans are tested and their performance is thoroughly documented. OQ is associated with equipment performance to ensure that the functions of the machines, measuring devices, utilities, and manufacturing areas perform as intended throughout all anticipated operating ranges in the selected environments. Items that have passed the IQ can falter in operation. So the components of the satisfactory OQ should permit a formal release of the performance qualification. So many times the operator or the instrument vendor, they give IQ, OQ, and they say, okay, because OQ many times actually PQ is also, they think that when they perform the OQ, they think PQ is also performed. So based on IQ, OQ, they write PQ too. So this is actually OQ is by the manufacturer or by the IBD, internal hardware calibration, software verification, maintenance verification, parameters calibration, internal quality control, they should check from the instrument side, precision of the analyze, verification of all the above with respective documents, and documentation of the above steps in OQ. So this is the OQ qualification report, that calibration successfully, checklist, OQ like quality control successfully, accuracy check successfully, and if there is any deviation. So this is OQ report, and then this is the conclusions, if test results are acceptable or not, and then they write the commits. So many times we are confused with OQ report and PQ report. So let's come to the performance qualification. The final steps of qualifying equipment is performance qualification. In this phase, the qualification or validation team verifies and documents that the equipment is working with reproducible results within a specific working range in lab setting. Team must create a detailed test plan based on the process description, and process performance qualification PPQ protocol is fundamental components of process validation and qualification. So performance qualification is manufacturing conditions such as equipment limits, operating parameters, and component inputs. And its purpose is to ensuring ongoing product quality is documenting performance over a period of time for certain processes. So this is process performance qualification, you can tell that. But many times I used to, during my inspection process, so they used to when I used to ask for the performance qualification or verification, So they, the lab director or the biochemistry head used to mention, okay, this is actually validated or verified in the by the instrument provider, and also this has actually the precision, accuracy, everything has been done, like, you know, in their R&D setups. Why we need to do all those things, like for performance qualification, a thorough list of
There is
data
no work
that
means if
we
you have got
record
laptop means you can
and
go and
analyze
log in your laptop.
during test, calibration, and
Apartment
validation.
Wi-Fi is there.
So we need to check
But Wi-Fi you can
precision,
ask
we need to
admin, it
check
will be.
sensitivity, we need to check accuracy, we need to check linearity, method comparison, carryover, and reference interval. Let me tell you the story. Like, we checked everything in our lab, but during one CAP inspection, when we participate in linearity surveys too for College of American Pathologists. But one time I got deficiency for linearity, because one of the tests which, like, you know, we participate in linearity survey, so I was not bothered about linearity check or AMR verification, analytical measurement range verification. So I was very cool, and I when they asked, okay, show us the linearity verification, I say, okay, these are the linearity surveys, and we performed very well the calibration verification, and it was linear. But then the inspector asked, when you have reported, you started test like, you know, result reporting. I said, okay, so and so date. So before that, is there any linearity survey? I said, no, but we actually enrolled for that, and then we did the accuracy, precision check, reference interval check, everything. So I don't need that, because we have enrolled for linearity surveys. So then I got deficiencies, because before reporting patient result, I have not done any AMR verification or linearity. So this is that, like, you know, one of the criteria to do the performance qualification. And this is actually basically mainly for CAP, but NABL also linearity, if you do, it's good, because it's actually many times we see tumor markers. Ferritin, more than 40,000, many people report. Many people report, I have seen, like, you know, 1 lakh, 2 lakh, 10 lakhs. So if you know your in analytical measurement range and CRR, or clinically reportable range, or extended measuring interval, is very good for us to do the linearity verification for our own lab setup. Then statistical data analysis is very important to check the pass and fail criteria. And so approval of PQ protocol by relevant department, mainly the quality unit and the lab. So why now I'll come to the same things, like, see this very simple test like TSH. So TSH, like, you know, 3 different report from 3 labs, and this is very common in India, because patients, when they do the test, and their clinician says, oh, this, I think there is some error. So they will go to 3 different labs, and there is variation even in 3 different reports. So let's see why. So then, do you think the sample integrity? I have seen, like, you know, samples are transported in different modes of transport. I've not seen elephants yet, but I have seen this scooty and auto and all. So do you think sample integrity is the issue for these 3 different TSH report? Or do you think the harmonization, verification is the challenge? So I am in the scientific division of IFCC, and I was part of the IFCC committee of thyroid function test. So actually, maybe in your lab, you have the A manufacturers and B manufacturers. In the same lab, that between the 2 manufacturers, the thyroid function test can be show variation 10 to 40%. So because of that, we need, like, you know, need to harmonize our test results. We need to standardization, of course, the job of the like IFCC and different other organizations, but harmonization of lab test is our job. Let's see how. So life is like riding bicycle. I believe in this philosophical lines of Albert Einstein. To keep your balance, you must keep me moving. So I believe this for my personal life, and then in the lab life. Like, for this TSH result, how to harmonize? I'm sitting in a small lab, medium-sized lab, or big-sized lab in India. So I have not read those articles of standardization of thyroid, and I don't know about the variations, how much variation and all. But what is how I can take part in harmonization process? So these two wheels are very important. Wheel of quality very important. Accuracy, precision, reference interval, like I said, linearity. This AMR or CRR or EMI, these are very important as a quality wheel. And cost, when you will go to even for R&D or academics or any research project or any lab project, like I want to have this, I want to start this test, like for AKI, acute kidney injury, I want to start NGAL, I want to start TIMP and IGF BP7. So I want to start this project for my student. So then the second question will come from your administration or the hospital administration about the cost. So these three M's are very important, three magic M's: man, machine, and material. So we need to harmonize between these two wheels, between the quality wheels and cost wheels. So let's see how. CAP college, and NABL both now in nowadays ISO 15189 2012, and they have seen the role of validation and verification. Validation is evaluation experiment conducted to determine whether a test system meets defined laboratory requirement, and verification is evaluation experiment conducted to determine whether certain specifications are met. So this is the difference between validation and verification. Many times we do the verification and we write in our report, PQ report or any other report, that this is our validation document. No, validation is quite extensive. So we can write verification protocol. So as method validation, as a part of method validation, we can write this verification protocol. So this verification is like analytical accuracy, then verification of precision, verification of reference interval, and verification of limit of blank, limit of detections, and linearity verifications like analytical measurement range, when range that can be reported without dilution or pre-treatment of samples, then extended measuring interval, EMI, according to CLSI EP34. Initially, we used to tell that CRR or clinically reportable range, that is the range that can be reported with dilution or pre-treatment of samples. So this is the first harmonization of value verification key point, reference interval. Oh, this is the thyroid fairy. She met this pregnant lady and she told, oh, I am a thyroid fairy. You can see me that as your results are too low. So like I said, that example of TSH in pregnancy, actually the reference cutoff is totally different, which is given in the reference textbook. So because of that, updating reference interval, many times go to many lab and see the reference interval of glucose, fasting plasma glucose, and PP. You see the fasting glucose, what is mentioned in ADA or what is mentioned in the packing insert. Many times what we are reporting is based on ADA 2006 guidelines. Many labs, we don't update ourselves. Basically we update ourselves, but basically we forget to update the reference interval. So reference interval is manufacturer suggestions, reference lab, reference textbook or article, and CLSI C28A3C. So this document, why I'm mentioning is for NABL, we may not we don't have to go for CLSI, but this is one reference documents. We can mention that and we can perform according to that. So CLSI said that 20 data for in the analytical measurement range or 20 healthy population, we don't need reference interval establishment, but for reference interval verification, we need minimum 20 healthy population. Here, what we do, we take the pre-employment, we take the executive health checkup samples, and we say that they are healthy. Do you think all the executive and executive health checkup healthy? So we need exclusion and inclusion criteria to define the healthy population in our reference interval. So this is we need for verification only 20 data points. And if we want to establish suppose your data is following Gaussian distribution in healthy population, then 120 is the sample size. Suppose it's not following the Gaussian distribution, minimum is 200, and FDA says 600. So because of that, suppose one student wants to establish reference interval for some new test. So if you want to establish, if following Gaussian distribution, 120 according to CLSI, if not following, then 200. So this is one of the project of ours, like how FDA say 200, 600. So because of that, we have taken healthy size, and these are the study design, exclusion and inclusion criteria. And we have done for the TSH and NTTPO and FT4. And we remember first year when we have done, we forgot to take NTTPO measurement, and 1,000 sample, but there was not a single sample can be used for this project. So next year we have done again NTTPO, FT4, and other exclusion and inclusion criteria. So we have, this is the reference interval. If you see, this is the population size, 800, and included based on the inclusion criteria, only 629. And this is by bootstrap non-parametric procedure. This is the reference interval of TSH, and this is by non-parametric. This is the reference interval, and the manufacturer's suggestion is quite different. So if we don't have, we can take manufacturer suggestion pack insert for reference interval, but if we can establish or verify, then we can verify. So this is in European Thyroid Journal, one paper of progress report of ours. The second key point is analytical accuracy. So agreement between the true result and test results. So bias is a measure of trueness, and bias is a difference between the test results and an accepted reference value. So comparison between the new method and the reference method most commonly used, and result using new method and on the certified reference materials recovery. But certified reference materials are costly. So because of that, we can't many lab, we can't take certified reference material to check. So we take the reference method. Suppose you have new instrument and you are using another instrument for a long time, or there is a gold standard method, so you can do the accuracy check with that. And for that, analyze minimum 20 samples by both new method and comparative method over the clinically meaningful range where medical decisions are made. Duplicate measurements by test method and comparative methods. Analyte concentration should be distributed in the analytical measurement range, and spreading the patient sample data over many days and runs are preferable. And difference between the test method and comparative method measures the trueness of the new method. It measured as a bias, and then compare the average bias between the two methods with manufacturer claims for allowable limits. Otherwise, check CLIA limits, reference books for clinically allowable limits. So this is one method comparison between the two instruments, and we have seen the bias. And then this is the linear regression analysis. So if you have done the, like here 40 samples was done, so we have done linear regression. So what is the slope, depicts the proportional bias related to calibration differences between the two methods. Intercept depicts the constant bias which may be related to calibration use, and R, or coefficient of correlation, depicts how close are the points to the line. So low R are due to poor correlation between methods and interfering substances or outliers. If R more than 0.975, then we accept that bilinear, simple linear regression, we can say that is verified. And plotting the bias plot, so ideally it should be 0, but it you can see what bias is acceptable, and then you can study it. Then verification of precision. Precision is the closeness of agreement between independent test results obtained under the stipulated conditions, and is expressed in terms of imprecisions like standard deviation, coefficient of variation of the set of replicates. So this is the current guidelines is 5 runs for 5 days. So total 25 replicates. So then when there is a, today you started the run of the low control or high control, 2 levels of control, at least minimum 2 levels of control. And if you can do in the 3 levels of control in the immunoassay parameter, and 5 runs today, then tomorrow 5 runs, and then for 5 days, so 25 replicates. So then users estimate within run precisions, that is SR, and manufacturer claim within run precision, that is sigma R, and verification value you calculate. If SR less than sigma R or SR less than verification value, then you say that users repeatability consistent with the manufacturer claim. So now coming to the limit of blank, limit of detection, and limit of quantitation. So these are the terms used to describe the smallest concentrations of a measurand, and that can be reliably measured by any analytical procedure. Limit of blank is the highest apparent analyte concentration expected to be found when replicates of the blank samples containing no analytes are tested. So this is the formula for limit of blank. And then limit of detection is the lowest analyte concentration likely to be reliably distinguished from limit of blank and at which detection is feasible. So limit of detection is determined by utilizing both the measures of limit of blank and test replicates of sample known to contain a low concentration of analytes. So you can take the patient samples who are in the near the analytical sensitivity values. So this is the formula for limit of detections. You can calculate from the limit of blank. And limit of quantitation is the lowest concentration at which the analyte can not only be reliably detected, but at which some predefined goals for bias and imprecisions are met. And the LOQ may be equivalent to LOD, or it could be at a much higher the concentrations than the LOD. So this is the difference between that and how we have established limit of blank. Like it involves 2 steps: determination of values obtained with blank samples or values obtained with low level of positive samples. Blank samples, often you can use zero calibrator for an assay. For LOD, low level of patient samples identified at or only slightly above the manufacturer claimed analytical sensitivity. So run 20 blanks or 20 zero calibrators or low levels of samples for limit of detection. If less than 3 exceeds stated blank value, you say that this is limit of detection is verified. So this is our this study. And yes, data. I can't make bricks without clay. The biochemistry and pathology or microbiology, yes, we have lots of data, but how to utilize that data, that says our role. Then comes our role. So I will not go because this is not much. Sigma metrics is not required. But how do our process looks like? Suppose you are going to your vacation flight to your dream destination. Will you select this pilot or this pilot? Of course, you want to land on the runway, right? But you want the specification to be met, but you want our clinicians, patients, they are not bothered about which rule are you following, 1-3S rule or R4S rule or 10X rules. They want the target should be met. So because of that, how our process are looking, how accurate we are, how we are following the target value. So because of that, our process, we are the pilot sitting in our flight, and our clinicians, our patients are the passengers. So they want specific, not only the specification to be met, they want near the target value. So because of that, measuring the variation, measuring the CB percentage, measuring the inaccuracy or bias is very important. And this is the calculation from where, like from total allowable error and bias and CB percentage, how we can calculate that. So when based on that, what is the rule in our lab? So we can customize number of QCs, QC rules, QC frequency based on high frequency analyze, normal frequency analyze, and low frequency analyze. So this is the formula for that. And total allowable error we can get from CLIA, we can get from recause biological variations or some others like Rileybeck and all. Bias we get from peer group, method group, and CV we can, for sigma matrix calculation, we can take 2-month CV or quarterly CV or long-term CV percentage. So this is how total allowable error selections. And this I will not like, in biological variation paper, you will see desirable performance, optimal performance, and minimum performance. What that mean? So this is that. So this is like few examples how to do the sigma matrix calculations, and with that, based on that formula. And this is the sigma matrix chart. Based on this sigma matrix chart, we can define which rule and what is should be the frequency we want to implement in our lab. And based on the method decision chart, we can see like where you can like implement like some analyze maybe at the marginal, some analyze good, some analyze at the Six Sigma level or world class. So this is like, customize your QC rule or frequency. This is in our lab. You see, this is the operating point. So this is in more than Six Sigma, this is acceptable. But when we started, you see the process in 2011, like, only 4.25, 3.78, 5.15. But in 2012, we have achieved till Six Sigma. So the monitoring is very important, and it's not a very hi-fi thing to implement Six Sigma in lab. So if you see, this is like, how data is displayed, and based on like existing rule and suggested rule. So based on your data, you can, that you may need to improve, monitor some of the parameters like electrolytes, and there you need to apply the rules. So this is very important. So now in summarize slides, list of equipment records, we need equipment history cards, instrument cards, work instructions, equipment calibration plan, maintenance record, daily, weekly, monthly, PM records or preventive maintenance records, post-PM performance verification report, and inter-instrument performance verification. Like I said about that inter-instrument, 20 samples between two instruments, 6 monthly is the requirement. We need to do it biannually. So this is like instrument history card of in our kind of setup. So this is where if there is any deviation is mentioned in the instrument history card near the instrument, so that everyone is aware about that. And this is work instruction is actually daily workflow process of all the instrument is mentioned. And this is another instrument work instruction. So everything, even the junior most technicians know what is the workflow. Then coming to the instrument calibrations, it should be all equipment must be calibrated following the preventive maintenance, breakdown and repairs, and more frequently as recommended by manufacturer. So we all know about the calibrations, and many like ABG analyzers that they have auto calibrations and all, and spectrophotometer, colorimeter check on absorbance, linearity, matching of cells in accordance with the manufacturer instruction or appropriate procedure. So I will show this is the calibration certificate, and this is different calibration certificate of different instruments, centrifuge. So this is some of the examples like how calibration certificate is given. So nowadays they don't mention they don't give calibration certificate, but they give one document that where everything is mentions, the raw data and all. So like that blank cell calibration, and this is the calibration certificate. And so cuvette check error, mean check range, room temperature and humidity, centrifuge maintenance sheets. These are in our lab, daily, weekly, monthly maintenance sheet. And this is, like I said, calibration linearity surveys, calibration verification, and like how it is performed for linearity surveys. And if it is in this patient, calibration was this was linear, but calibration verification was different. So for that, we have done the AMR verification or analytical measurement range verification. We have taken low patient samples, we have taken high patient samples, and this is then 0.75 low and 0.25 high. So this is the way to do the AMR verifications for if the linearity samples or linearity surveys, they show outlier. Or you can take the new calibration lot and then you from the previous linearity survey samples, and sometimes that also is one of the procedure. So this is some examples. So ongoing performance verification like carryover after PM, linearity check biannually, precision check after PM, retained sample testing annually, lot-to-lot verification, very important. Inter-instrument, lot-to-lot verification, many people do it very incorrectly. So maybe some days I will see how to calculate the critical difference in lot-to-lot verification. So I got non-compliance, and from that we actually evolved. And inter-instrument verification is biannually, calibration verification as and when required. And this is the verification protocol. And as I have said, that first slide, when that IL-6 in one lab showed 3,000, another lab showed 6 picogram per ml. So then there was need of integrity. Sample integrity was when sample was kept outside in room temperature. So IL-6 showed increase. So because of that, we checked in our kind of setup, we checked the pre-analytical like sample integrity. We checked in room temperature 2 to 8 degrees centigrade, minus 20 degrees centigrade in serum sample, plasma sample, and we have checked the variation. So this is very important. When anybody reports you any interferences, any sample integrity issue, so you can actually in your lab or in your kind of setup, you can verify the pre-analytical issues. So because of that, we have 0 hours to 72 hours. We have seen like if there is any variation or not. But for IL-6 in our kind of setup, we have, this is hospital kind of setup, we have not seen much variation. But yes, IL-6 when it is kept at the room temperature, maybe at the airport or maybe outside the lab, so it's IL-6 sample values increased a lot. So because of that, trend analysis is very important. So for pre-installation site assessment, purchase order, invoice, parts list, operational manual, procedure of equipment and test, and then training package is very important for IQ, visual inspection, assembly, site preparation and environmental requirement, power check, training and post-training evaluation documentation, support service, name and contact details, IQ review and approval, OQ calibration schedule and procedure, IQC maintenance schedule and procedure, and OQ review and approval. And for PQ, accuracy, precision, linearity, reference interval, carryover, check the tested samples, lot-to-lot verifications, key operators, PQ review and approval. And I acknowledge our team. Thank you. 5 minutes to 11. My actually time limit is still 11. Thank you.
Thank you, ma'am. Any clarifications from the participants or any doubts you can just clarify now? Any questions from the audience?
Good morning, madam. A very luminous talk, I should say, with real life examples, what we keep seeing day and night. And of course, highlighting the urgency for investigations as well as the limitations at that time during the outbreak of the pandemic, particularly the second wave. We also went through similar situation.
Thank you, sir.
Madam, just one thing. Thank you. Just one thing. We keep seeing an instrument which does undergo periodic calibrations. There can be few critical values, maybe because of sample harvesting, transport of sample, preservation of sample, etc. And quite often, as clinicians, we go by reference ranges which we have studied. It keeps changing. The best example I would quote is serum cholesterol or creatinine. When I was UG, we used to say 250 milligrams percent cholesterol or 1.5 creatinine. That has fallen drastically. So reference ranges, you rightly mentioned, it keeps changing. Would it not be ideal to have frequent updates for clinicians as well as of course, clinical pathological meetings we have. In addition, interdepartmental meetings, maybe once a week or once in fortnight, where we can discuss the critical values or values which we don't concur with, and sort out such things.
Yes, sir, absolutely. Like reference interval is really a challenge. Many times we use the reference interval based on the US populations or European population. So now, like recently, we have started one ICMR task force. I am one of them in ICMR task force. I'm part of that committee for reference interval, because this was actually much needed, and long term we were waiting like to start the Indian reference interval for all the analytes. So the journey has just begun. We were trying, trying. I am part of IFCC reference interval team, but again, the reference interval for different ethnic group is different. So because of that, this ICMR like task force we have started. And as you mentioned, the critical call out. Let me give my example in my hospital. So critical call out, I have taken the reference textbook. So then we have the clinical pathological meet, and we called all the emergency physicians, intensivists, and the medicine specialists, and actually we invited everyone. So when I displaced my critical call out based on the value given in my textbook, so they all have disagreed.
Yeah.
All the values, actually most of the critical call out was disagreed by the clinicians. So because of that, I changed completely my critical call out. And then many times the NABL team or NABH team, mainly for NABH hospital, or we are JCI, many a time when JCI or NABH comes, they see only critical call out is proper or not. So for those, it's very important to take the clinician suggestions. NABL many times has ask us to show us the reference. So that time the reference is many times is not available. You discuss with clinicians, because reference textbook many times they are outdated. Maybe it will come after 5 years. So we can't give a critical call out of different for this wrong critical call out for 5 years.
Yes, ma'am.
Because it takes time to update. So because of that, any update from our publications and clinicians here is the for critical call out is the most important. So we just take the clinician signature and we take critical call out from the clinician suggestion. We don't take from reference textbook, because when we used to take it, maybe we were following there was no non-compliance for CAP or NABL. But the non-compliance with our clinicians, they were not agreeing with any of the critical call out given in our textbook. So because of that, for critical call out establishment, is very important take clinician suggestion and take their signature. So NABL, JCI, NABH, or any other CAP, they don't disagree that you are taking clinician suggestions for critical call out.
Yes, ma'am. Thank you, madam. Thank you.
Any questions? Any questions from the participants? If not, shall we move on to the next session? Before that, I want to thank ma'am for
Hi, I have
session.
I'm really honored.
Yes, ma'am.
Thank you, ma'am.
So, ma'am was showing one slide where she was discussing about IL-6 variation in two labs.
Yes.
Yes, ma'am. So, how did you resolve that? Was it because one of the sample was kept in higher temperature for a longer time?
Yes. That lab actually kept because that has traveled from faraway location, and because of that was kept room temperature for the long time. So because of that, they have seen the variation, and this was the sample integrity. That IL-6 variation, like 3000, you can see the difference from 3000 to 6. So that much difference can happen when samples are not kept properly. So because of that, many times we get call from clinicians that your lab report is not matching. So the most of the errors are actually pre-analytical or pre-examination. So this IL-6 is the best example. Like I think we all have seen that, like in WhatsApp, that IL-6 in one lab. So then we thought that lab is wrong. Actually, that lab is not wrong. The analytical process is not wrong, but actually the sample integrity was the issue.
Ma'am, another thing, you also spoke about this short verification that you did before you started IL-6. Can you just tell me how did you follow that? You just ran the controls?
No, they don't follow that for, this is only for the pandemic situation. So if
Okay.
you do follow that for like, now, so nobody, auditor or inspector will agree. This was only pandemic situation and emergency case. So I have reported that case. So after that, I was because of time constraint, I was not able to show you the IL-6 verification. I have kept that my presentation. But after that, after everything, after that patient sample we reported, we have done proper verification of 5 days protocol. And many times we do 20 days protocol also, because this is a new parameter. But that is in pandemic situation, to save one patient life, we want to do anything. So that was for that. So we have checked the precision or reproducibility. We have checked the control. We have checked the reproducibility 20 times. Every single one, we have processed the sample and we checked the reproducibility like SR and sigma R, and it was as per the manufacturer claim. So we accepted that. But that is only for the emergency situation, to save one patient life. And that was only due to COVID pandemic, for nothing else. If I document that, for now, if any assessor comes or inspector comes, I will get deficiency or this thing.
Okay, ma'am. Thank you.
Any more questions? Any questions from the participants?
I'm looking forward for Dr. Sujay's talk. He's such an eminent speaker. So I'm looking forward to hearing from him.
Thank you, ma'am. Thank you for the excellent session and guiding us on the GCLP guidelines, equipment, calibration, and verification. Thank you for accepting our invitation and sparing your valuable time.
Thank you. Thank you so much.
It's a pleasure, ma'am. We shall move on to the second session now by Dr. Sujay Prasad, sir, on why identifying errors forms the basis of GLP. Over to you, sir.
Thank you. Are you able to see my screen?
Yes, sir. Yes, sir.
Yes, sir.
Thank you. Thank you at the outset for giving me this opportunity to share my thoughts on good clinical laboratory practice. And this I'm following a very elegant talk by Dr. Barnali Das. I thank her for making such a complex topic of IQ, OQ, and PQ, just 6 letters, but she made it relatively simple. And every time I listen to her, I learn something. Dr. Barnali. Moving on, next 45 minutes, I hope to complete this in 45 minutes. I would like to take you through why identifying errors really is the basis for good laboratory.
So your voice is echoing, sir.
Is it echoing now?
No, sir.
Yeah.
You're clear.
Yeah. Okay. Thank you. Over the next 45 minutes, I'm hoping to, of course, this relationship between GCLP and quality is relatively well known. I don't think there is really much to say there. Then the relationship between quality and errors.
So can you share your slides, sir?
Isn't it? I thought it was visible.
It was visible, now it's not, sir.
Is it? What about now? Is it visible now?
No, sir. No, sir.
Okay. Just a minute.
Sir, now it's visible. Can you please put it in the slideshow, sir?
Is it on the slideshow now?
No, sir,
Because
it's
for
not
me, it's
visible. It's not visible still, sir. Yes, sir. Now it is visible.
yeah, it's visible, but the moment I put it into slide, I need to see.
I request participants to mute their this one.
So you can see this window, is it?
Yes, sir.
But the moment you put it in,
Kindly participants mute.
Are you able to see the presentation view?
Yes, sir. Yes, sir.
Now?
Yes, sir. Slideshow is not visible, but the slides are quite clear, sir.
Okay, so I think I'll have to do with this view, because I don't think it's coming into the presentation mode. But is this okay? Can I?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. You can go ahead, sir.
Okay, so the next 45 minutes, I'm hoping to do this, building a relationship between GCLP quality, which I think everybody knows, and quality and errors, and why identifying errors becomes the basis for good laboratory practice. I'll share some experience on errors that we have had in routine work. When you look at GCLP, and I think the ICMR has clearly brought out the guidelines for GCLP in 2021, and I'm taking some excerpts from that document. It clearly says that this document has now been revised to be adopted uniformly in medical laboratories, whether it's involved in clinical research or patient care. So it applies to both segments of laboratories, and the GLP is basically a set of principles that define a quality system. That's where we would want to link the GLP with the quality. GLP is nothing but a set of principles. Really, it gives you a very high level understanding of how the organizational processes need to be planned and set for the intended purpose, and it is to promote the quality of the test data. So there are many benefits to laboratories that are GCLP compliant. Now, GCLP and GLP are more compliance based. You can take it as an approach to compliance, but I would look at it as a approach to improve the experience of the patient when he or she gets the results. So there are many benefits when the lab is GCLP compliant. Laboratory results are reliable, reproducible, and auditable. The incidences of false negatives and false positives are reduced. Results are assured to be of the highest quality. Results are comparable to those obtained in other compliant laboratories around the world, building the confidence of staff, sponsors, and clients. I think this is a very important aspect where GCLP contributes. Resources are efficiently managed, minimizing waste, and uniform and standardization of systems are achieved. Now, practically speaking, when we start looking at GLP and all of those, it looks nice, but on the ground, there can be challenges, and these are what I got from some of the articles that I went through. So we all sometimes look at results with some background information, and that background information for us as humans can contribute to the bias. And when we are biased as humans, the results that come can be interpreted in different ways. So the first statement, that is not evaluating the results blindly, can lead to inaccuracy. So as human beings, we can't resist bias. So if we don't remain blind to the conditions, then we can't be sure our results are accurate. So it's a very tricky statement to make, but nevertheless, we need to keep this in mind, that the bias that we have in our minds should be minimal. Not calibrating all equipment correctly. Of course, this I think Dr. Pannalidhas brought out very well, that it's important that we ensure calibration happens at the right time. I have a experience to share there, and I will do that. Not documented, not done. I think it's very clearly mentioned, by not recording all data at the time it was generated, we risk items being missed or misinterpreted. I think NABL also very clearly says, if it's not documented, it's not done. Not wearing personal protective equipment all the time, particularly with the recent pandemic, I think it's become more relevant. Though here it's mentioning laboratory chemicals and the risk of danger and cross-contamination from humans to affect the samples, I would also add to this the infectious agents that contribute to the problem, and wearing a PPE is a good laboratory practice. Relying on first-time measurements can lead to challenges. It is check, and check again. Practice the habit of double and triple checking all of your measurements till you develop the confidence. Failing to run a control sample is definitely a no-no. It has to be done meaningfully. Like Dr. Pannalidhas mentioned, knowing your sigma will help you decide how frequently the QC needs to be run and how many levels needs to be run. And that gives you the confidence to be doing the right thing. Using abbreviated notes, I think all of us have experienced one way or the other during our post-graduation or subsequently, how abbreviations has caused confusion. Inconsistent use of tools or equipment, I think it's very important. The exact measurement between two different pieces of equipment can vary, and this was again highlighted in the previous talk by Dr. Pannalidhas. And we need to see how much of a difference there is. Is it acceptable or not? Failure to communicate with those working alongside you, very important. I think one of the key challenges in a lab is communication or lack of it. And finally, avoiding completion of refresher training. Each one of us, when we finish our post-graduation, we think we know everything. And then we start performing our duties, not realizing that with time, change happens and we are not updated on those changes. So the relationship between quality and errors requires us to understand quality. What does quality mean? And for me, it was a very subjective term when I completed my post-graduation. It meant something really good, but I did not think it was measurable. And the question was, can we measure quality? And if it is, the answer is yes. What is the measure? Is it precision, accuracy? How do we measure pre-analytical quality? How do we measure post-analytical quality? So this can get very complex to measure. And if the answer is no, I would recommend this book, Think Again, from Adam Grant. And he talks about how in turbulent world, there's another set of cognitive skills that might matter more. And that is the ability to rethink and unlearn. So whatever we have learned over time, I think it's important that we relook at it. And is it time to unlearn and rethink is something that we need to look at. Because if you can't measure something, you can't manage it. And that was from Peter Drucker. So if it matters, we should be measuring it. And what's the measure is the question. So for me, quality is absence of errors. It's a very short statement, but for me, a very powerful one, that if you can measure your errors, you can measure your quality, or like they're inversely proportional. So if the errors go up, the quality goes down. And if the errors go down, the quality goes up. So it's very clear that the focus is on errors, which we need to identify, record, analyze, find the root cause, and eliminate. Very often, we as humans have a fear of errors. We do not like to be seen from others' viewpoint that we have made an error. And that fear prevents us from either identifying it, or even if we identify, we do not want to record it. And that takes away the opportunity for improving, because at the end of identifying an error is an opportunity to eliminate that error. So I would like to take you through an example of medical significance of non-conformance. I've put this table actually when it's in the presentation mode, it's supposed to be building up one column at a time, but nevertheless, since you're not able to see the presentation mode, I'm going to explain to you. On the columns, I have put where the non-conformance or where the error has happened. And I've also provided in the column where the error has been identified. And subsequently, based on these two aspects, how serious or how significant is it medically? Let me take a simple example of a patient walking in for lipid profile. And the patient has walked in and is sitting on the phlebotomy chair, and the patient has been asked by the phlebotomist whether he has come fasting. And the patient says that he's not fasting, he's had a glass of milk. And then before putting the needle in, the patient has been told that lipid profile needs to be fasting. So the error has been identified. And the patient has been told to go back and come back next day, so that there is a fasting state before the sample is drawn. So the error is identified and the medical significance is minimal. A similar situation, the blood is drawn without asking this question whether the patient was fasting, and the patient has not bothered to tell the phlebotomist that he has had a glass of milk. So when the sample has gone into the department and analyzed, the triglycerides are at 2000. And the person the technologist who's doing the test finds that the result is pretty high and needs to understand if the QC is okay, the calibration is fine. So everything is well set. But the technologist goes one step ahead and finds out from the phlebotomist whether the patient was fasting. Now the phlebotomist doesn't know that. So he makes a call to the patient and finds out if the patient was fasting, and the patient says, no, he has had a glass of milk. So that has provided information that the 2000 milligrams per deciliter triglyceride is probably because of that glass of milk that the person has had. So the error has been identified. So the result has not been released. There is a significance, and that significance is a delay. Of course, a needle prick has happened, but it's minimal. Now let's go to the next level. The triglycerides report has been released because the QC and calibration, everything is fine. And the result has come into the authorized signatories table. Now, while releasing the report, the authorized signatory feels that 2000 milligrams triglyceride is not acceptable. If the QC is fine, calibration is okay, and if the patient is fasting, then it's possible that we can release that result. So the authorized signatory gets to know that the patient has had a glass of milk, so doesn't release the result. So far, so good. I think the patient is not affected except for delay and having had a needle prick done. Now the dark line that I have put after the first 4 columns is when the result has been released outside into the patient's hand or the clinician's hand. And the same let me take you through further. The same authorized signatory realizes that the QC is fine and the calibration is okay, releases the triglyceride value of 2000 milligrams per cent. And now the report with that value in the lipid profile is sitting on the physician's table, and the patient is sitting across the table talking to the physician. Now the physician looks at the result and he says, were you fasting when you went to the lab? Patient says, no, I had a glass of milk. So the physician said, didn't the lab ask you if you are fasting or not? The patient would say, no, they did not ask me. They drew the sample. And so the error has been identified by the physician, but it has already gone past the lab. Now, this is where the perceptual issues start coming about quality. Now, the error has been experienced by the physician and the patient sitting together. Now, both of them would wonder if the lab is doing the right kind of work. If a simple question cannot be asked before the blood is drawn, how can the lab release results of such high values? So the perceptionally for the lab, it takes a beating, but for the patient, the physician is not going to start any treatment. So the patient will be asked to go and get another sample done on a fasting state. Now let's look at the next scenario. The physician or the clinician believes the lab has done the right thing and believes this particular lab does a great job and goes ahead treating the patient for a high triglyceride, whatever the treatment may be. And after a while, the patient is curious and gets to do his lipid profile again, but this time he doesn't have the glass of milk. And his triglyceride comes down to say 256. Now 2000 to 256 in a short span of time may or may not be practical, but nevertheless there is a difference, and the marked difference may not be attributable to the treatment. There is a serious damage done already, both to the reputation of the lab as well as to the patient, because he's had treatment of some sort. And the last situation is really grave because the full treatment is given, and then if the NC is identified at that point in time that the entire process or the lipid profile was altered because of a glass of milk, it is good. Otherwise, it can be really troublesome. So you see how it is important that we identify the error well within the confines of the lab before the results are released. This is just a snapshot of a very broad overview of the processes in the lab. And all of us are aware that most often the errors happen in the pre-analytical space, of lesser degree in the post-analytical stage. And this is what I keep hearing, and we analyze in our own lab, that the analytical errors are less. But I have a different take here. The errors, when we consider all the errors of the QC, I would think that they would be far more, because what we don't consider as an error is when we look at a QC that is outlier, we correct it, and then the QC comes in, we don't take that as an error. If we start taking all of them as errors because primarily that was an error, then the analytical errors, I would think, would be far more. That's my view. Over the next couple of minutes, I will share with you experience over 27 years. Start with the pre-analytical examination. In 1998, we had about 150 to 200 patients per day, and we were having handwritten sample IDs with almost 2 to 3 transcriptional errors in a week. And this was real inconvenience to patients and a lot of stress to the staff.
ಏನು ನೆನಪಾಗ್ತಾ ಇಲ್ಲ ಅಂತ ಬಡ್ಕೊಂಡು ಸಾಯ್ತಾ ಇದೆ. ನಮ್ ಸೀನಿಯರ್ಸ್ ಎಲ್ಲ ಸುಮ್ನೆ ಓದು ನೀನು ಹೋಗ್ಬೋದು.
Kindly mute.
So the sample identification can be quite challenging. If we look at these four tubes appear to be fine, well written, but then when I look at this one particular tube, my understanding is this is either 330512 or 330572. Only the person who's written that number would be able to tell me what it is. So that can be one challenging. And the second error is already there. The series of numbers is 3299, whereas the last number is 3229. Instead of the third digit being a 9, the person has written it as 2. So within a span of 4 tubes, when human error attention span is so less that it can really affect the entire process. So the solution is a simple solution, a barcode, because these barcodes are very convenient. They are time tested, and in 1998 when we introduced, there were different ways of getting these barcodes done, and we applied it to almost every sample that we had. Today we have about 2,500 to 3,000 patients a day, and we see it's not that errors have disappeared, but errors have reduced. We see about less than 10 errors per year with this workload. And when the errors reduce, the perception of quality goes up. So the patient's experience of quality kind of becomes better. Apart from the beneficial effect of barcode being a positive ID, it helps in sample tracking, quick recall of sample IDs, and can be used in a variety of processes. So we basically identified the error, we recorded it, analyzed, fixed the error by a technology which was available, and that gave a perception of improved quality. So while that error reduced, there were other errors that started creeping up. Wherever there was a delay in phlebotomy process, and there were missing tubes that were there. So for which we tried to look at improving the process. We brought in a tube labeler, which allowed us to allow the staff also to ensure that they could easily complete their labeling process effectively before collecting the blood sample. And our LIS tube provides the tubes that needs to be collected, and it comes up in a tray and provides information other than the patient identification. It also gives us the order of draw. So you have the hematology, biochemistry, and all the tubes, and it gives you the order of draw 1, 2, 3, and 4. Of course, even in this, there is something missing. I would like to know what is the total number of tubes for this particular patient. So there should be a serial number with total number of tubes. So it should have been 1 of 4, 2 of 4, 3 of 4, and 4 of 4. So this gives the phlebotomist also an idea of the number of tubes, and hence missing tubes as an error was no longer seen. From there we go on to post-analytical examination, and this was a very serious one. In fact, many years ago, I got a call from one of our customers, and she said, "Doc, I've got a report from your lab for pregnancy test. You have reported it as negative, but I have done it at home and the test at home is positive. What do you want me to do?" I said, "Please don't do anything. Let's repeat the test." And very clearly, this is a major non-conformance. This is something that I hope never happens, because this can lead to a lot of complications, including legal ones. So as I keep the phone down, my staff comes running and tells me that a blunder has been done by her. I said, "What happened?" She said the test was positive, but because she had a lot of samples, she entered in the register as negative. I said, "That's fine, but what's the procedure that we follow in the lab?" the test is done by technologist, its result is entered into the register by technologist, and finally it's verified by the supervisor or the team leader. So I asked what happened to the supervisor. Now the supervisor was in the 4th floor while the test was done in the 1st floor. So the technologist took the register to the supervisor, and this technologist was a very diligent worker. So the supervisor looked at the technologist and asked whether the result was negative. She nodded her head, and the supervisor countersigned a negative result. When 2 people countersign, I signed off the result. And that kind of the result went out of the lab. Now, is the error system-based or human-based? Now, I would think it's system-based because the system allowed the error to happen. The problem is not related to the person doing the test. The problem is not related to the person supervising the result. The system allowed the error to happen because verification was difficult if the supervisor was not in the department. Now, based on this, we decided to apply a process change. We brought in a camera and attached it to the LIS. And every time a pregnancy test was to be done, we would capture it into the LIS. And I called all my team and I said, we have done a blunder. We need to start doing this. As soon as they saw this process, they said, sir, why not? Why only pregnancy test? Why not do it for other tests as well? So right now we do it for blood grouping, tube tests, cultures, and a whole lot of tests. So the verification of test result is now system based. Technologist captures the image of test device. That itself gives a lot of confidence to the technologist because he or she knows what is the device, what is the result, and what has been entered into the LIS. Now the supervisor doesn't need to see the test device. He or she will look at it from any computer in the lab and verify. And finally, the authorized signatory gets to see it a second time before signing out. So what we basically did was to identify the error and enhance the signal so that all the other repetitive action is reduced. That's what I call as reduce noise and improve quality. From there, I come to instrument calibration, which is a very essential aspect of every analytical process. Whenever I ask my staff, how do you define calibration? Most of us find it very difficult. But over the years, one of the books gave a very simple definition. Calibration is the ratio between the signal and the concentration. It's a very simple definition, but a very nice one to remember. It's a ratio between signal and concentration. Its importance is often underestimated, and I'll tell you why. And the significance is poorly understood. The general perception is calibration costs. So when we tell our staff, did you calibrate? They said, no, sir, QC is fine. So there's no need to calibrate. Otherwise, cost is going to go up.
Sir, your slides are not visible, sir. Your slides are not visible.
Again?
Yes, sir.
Can you see it now?
No, sir.
Not yet. I don't know why it keeps going off. Let me.
You can share it again, sir.
Yeah.
Participants kindly mute.
Can you see it now?
No, sir.
Not
Yes,
yet.
sir. Yes, sir. Yes, sir.
Yeah.
You can join the teams again.
Actually, your things are seen, so just shift to the slide.
Yeah, that's what I did, but for some reason, tree is not stop
you
sharing.
are already yes.
Because I see the And see the
Maybe
presentation there.
stop sharing and then reshare.
Do you
Now
see it?
Yes, sir.
Yes, sir. Yes, sir.
Yes.
Okay. So the general perception is that calibration costs, and there's a problem if we have to regularly calibrate. And I find that extremely challenging to explain, but that I will try and do it in this slide. So when QC is, the general perception is when QC is fine, let us not calibrate. So only when the QC goes out, we need to calibrate. Now QC going out for me is like fire starting in the lab. And I ask my staff this, do you want the fire to start and then you want to put it out? Or do you want to prevent the fire from starting? That's when the answer comes that we want to prevent it. And then we need to revisit the calibration schedule appropriately. And I will explain to you in a while. So in the top part, I did allow the QC to go out and then calibrate. In the second half, the lower part, I'm calibrating even when the QC is not going out at a defined schedule. And you will realize that fire will never start, meaning QCs will never go out that frequently. And this is what I mean. The manufacturer's recommendation for calibration stability is say 28 days. So we put 28 days as the calibration frequency, but on the 21st day, we have a QC going out. Now the QC going out could be due to various reasons, and it could be instrument, reagent, QC material, and calibration. If the QC is gone out because of calibration, then what I'm going to tell you now is going to apply. Okay, so the QC has gone out on the 21st day of the calibration frequency, which is actually 28 days. Now what do? We typically calibrate after the QC is gone out, and we continue the 28-day calibration schedule. But in my view, we should come out of that and actually start calibrating on the 21st day or the 20th day. We know that the QC has gone out on the 21st day. Our calibration frequency should change from 28 days to 20 days. And that's when we realized in our own experience that when calibration is done meaningfully, QC going out is not often. So it's a planned activity. Internal QC or imprecision is far lesser. Precision is better. Our EQUAS results are better, and confidence in result reporting starts to appear. Coming to examination, we have just 4 minutes left. I think I have a lot more slides. Shall I skip all this and go to the summary?
No, sir, you can go ahead, sir.
It may take a while. That's the reason, because
That's okay.
Okay, fine. Let me take you through in the whenever you feel I'm going past the time. Let me know. So in examination, fundamentally, I ask myself, how do we know the result that we just signed out is reliable? And the answer that I tell everybody or I get from is that we run QC every day. So what? The values are within 2 SD. So the next question is, what is 1 SD? That's when all of us are lost in thought. How do I define that one standard deviation and set a goal? And when I look at various answers, the answers I get is manufacturer's SD is set. Laboratory has defined its own SD. 1/4 the reference range is set as SD. NABL assessor has told the lab to set it as a particular SD, or the service engineer has told to set it as a particular SD, and that is setting the goal. And that's where my concern is. Setting a QC goal is very important. And should be done before analyzing the QC data. It's like the football field where you stand and start kicking the football wherever it goes, and if you feel that is the goal post, then that becomes your goal post. But all of us know that every football field has an international guideline to set the goal, and that is what it is. So managing information before and after setting QC goal is very important. Suppose we have the QC goal as the goal post as the QC goal, and it's 1 standard deviation. That is one level. Suppose I don't know the international guideline, I'm setting a larger area as my goal. That is the second level. And finally, I don't know how to set the QC goal, so I use the entire football field as my QC goal. And when this happens and I run my QC, it looks amazingly good. All QC values are well within the range. But when I soon realized that my QC goal setting itself was an error, when I bring it down to a tighter schedule, I'll see that 3 values are outliers and I have falsely accepted it. But if I actually go to the international guideline, there's only one result that is within 2 standard deviation. All the others are actually outliers, which I have falsely accepted, and based on which I have released results to my patients. So in the current practice, when I look at QC goals, there are no QC goals, literally none. Just running the QC on a daily basis is the goal. But running QC is only the beginning of a journey that provides insights into the QC process. Or the QC goal could be 2 standard deviation, not knowing what 1 standard deviation is, as I just mentioned. Or it could be a laboratory derived standard deviation or a historical standard deviation, or it could be a percentage of mean, which is seen in many reference books, or it could be CLIA or biological variation. So basically, the answer to allowable limits of performance comes from the 2015 Milan quality hierarchy, where goals are based on analytical performance related to clinical outcomes, which is the most difficult one. It is goals based on biological variation or goals based on everything else. These are the 3 acceptable goals that we can set in our lab. And we all know that we can get the mean, standard deviation, CV, bias from our own data. But what is important is to get the total error allowable or the goal, international goal, from literature. I'm sure I'm not going to go into details of this. The sigma metric is an expression of errors in the system. The reason I told identifying errors is the basis of good laboratory practice. Even when you look at your sigma, it's an expression of errors in the system. Ideally, it should include all aspects of work. And currently, the discussion is limited to the analytical phase. So I told you about total error allowable, which comes from the Milan hierarchy. The bias and the CV comes from our own data. Now, with this, can we measure our sigma? Why is it called Six Sigma is another thing which was a paradox for me, because we all talked about 2 standard deviations with being well within 2 standard deviation, but here we call it a Six Sigma. And the answer is in the fact that the distance of the test value to the total error allowable is what sets the sigma measure. Now, the total error allowable was initially set by the Stockholm Consensus in 1999, subsequently Milan hierarchy in 2015. And clinical outcome studies are extremely few and far apart and very difficult to achieve. The second best is biological variation derived goals like the RECOS goals. And of course, there is a lot of controversy there as well, a lot of discussion happening. And the last choice is best or state of the art, in which you have RCPA, CLIA, RelayBack, each of the regional proficiency testing providers giving their guidelines. But you'll see from this list that the manufacturer's goals, the laboratory derived goals are not figuring in this list. So in my view, they are not acceptable. So when we look at the distance between the test value and the total error allowable, the number of standard deviations existing will be the sigma number. So if you look at the Milan hierarchy, the clinical outcome, the TEA, the total error allowable, is so tight that the same CV and bias will give a sigma of 3.5. The second level will give a sigma of 5, and the third level will give a sigma of 7. So when anyone talks about a sigma number, that my blood glucose sigma is 6.5, the first question that we need to ask is, what's your total error allowable? If the total error allowable is the lowest, then there's an opportunity to improve to the next level. But if the sigma number is based on a goal that is not within the Milan hierarchy, then there is a challenge. The goal is set manufacturer or the laboratory.
Kindly.
So the total error allowable comes from the Milan hierarchy. Inaccuracy comes from EQUAS, various forms, and this imprecision comes from IQC. So mean standard deviation, CV, bias, total error can be achieved in the lab. When I say achieved, these are the values that come out of laboratory data. But we can set goals for each one of these, except the mean. We can't really set a goal for the mean. The standard deviation, CV, all of them can be derived from literature. I've given an example here. The hemoglobin CV is 0.72, bias is 0.692, and total error allowable is 4.19. So the sigma here would be 4.19 minus 0.692 divided by 0.72, which is 4.85. Now the same CV and bias, but the TEA, total error allowable, has changed to 7, and you see how the sigma goes up to 6. It becomes world class. And we start applying this to all our analytes, wherever they are quantified. And then you start looking at the sigma levels with biological variation database or with CLIA. And you'll see that the biological variation database, or the desirable level, that is the second one, has a lower sigma compared to the CLIA. CLIA allows a lot more flexibility, and hence your sigmas will be much better with CLIA. But you should not rest with that. You should try to achieve better sigmas with biological variation database desirable outcomes. So what's the significance of the sigma number? Typically, sigma of 6 or more is world class, which is essentially 3.4 errors per million. In healthcare, sigma of 4 gives a confidence of 95%. Sigma of less than 4 will need attention. In fact, if you run QC with every sample also, you will not get the confidence of releasing the result, because if the sigma is less than 4, both the imprecision and the inaccuracies are much higher. So I will not take you through this. So we know our sigma. What next? We have to organize data, calculate sigma, monitor sigma, and take action. So that's what we did. We classified all the tests into different sigma levels, and then we looked at less than 4. And in October 2015, we looked at the sigma, and you see the calcium sigma is 0.45. In December 15, it is 0.69. So obviously we needed to do something, and we looked at the reason was imprecision was high, and we looked at what are all the contributing factors for imprecision, and quality control material was one of them. And then when we looked at the root cause was our staff were vortexing the vial of QC material while they were reconstituting, and because of that, the values were going imprecise. The manufacturer's recommendation was to gently swirl the vial while reconstituting, and just this one change of reconstitution led to a sigma change of 0.36 to 6.06. Now you see, question here is, would this sigma, low sigma, actually affect patient care? Not really, because this was a variable that affected the QC material and not the patient sample. Of course, we need to keep in mind that this also will lead to better understanding of how to handle patient samples going forward. Nevertheless, this was a learning for us, that just a change in the way we reconstituted the QC material resulted in a better sigma. Yeah, this is what a small change in the process of reconstituting QC material resulted in sigma moving from 0.27 to 6.06. And this is what we are trying to do. We go at the lowest level of Milan hierarchy and try to achieve a sigma of 6. If we achieve a sigma of 6 with the lowest level, we try to go to the, we set the TEA to the next level and then start in that direction. So in summary, errors help identify areas of improvement. Root cause analysis and corrective action is important. Setting relevant goals before analysis of QC is also very important, as I showed you. Sigma metric helps. It gives a combined uncertainty of both imprecision and bias. And for, as Dr. Barnalidas mentioned, sigma levels help set QC frequencies. And all of these lead to good laboratory practice and GCLP, not only from the compliance perspective, but actually from the patient care perspective. Thank you very much.
Thank you, sir. Any queries or questions from the participants? Any questions?
Both my audio and video from the chat, I'm seeing that my audio was not clear.
దీన్ని నేను మాట్లాడేప్పుడు అన్మ్యూట్ వాళ్ళు చేస్తారా నేను చేస్తాను పెట్టాలి.
Sir, audio was clear. We can hear an excellent talk, sir. So
thank you, Dr. Barnali.
Excellent
nice
talk.
to see you and listen to you.
Any questions? Dr. Sindhu?
Yeah, hi, sir. Can you suggest any book or any resource from where I can read more about these sigma metrics? Because we don't learn this while we are doing our MD. Now we are suddenly exposed to all this. So if you can suggest some reference materials.
You see, the thing is, if I ask myself, was there a single book that gave me all this information? Not really. What happens is when you see somebody talk of sigma, you start looking at what is the purpose? Why do I need to look at sigma? Because sigma is a number that gives you a snapshot of how your results are reaching the patient. And when you start looking, okay, what constitutes the sigma? You start looking at total error allowable, which is very important. You look at bias and all these three are available. And then now with the Google, you have everything and in a click of a button. But for me, it's garbage in, garbage out. You have to make sense of the data that is or information that is available in Google. Once you make sense of that information, it becomes knowledge. Knowledge is useless if it is not applied in daily life. So once you start understanding the entire concept of sigma through different resources, you start applying it in your area of work. Any quantitative analysis, you can apply sigma. And you will start looking at, in fact, we have started applying sigma in our pre-analytical and post-analytical. What we do is we calculate the total number of opportunities where things can go wrong. So if I have a registration desk and the person has to enter the name, gender, age, contact number, and the tests that have to be done. There are 6 processes to be done. Now 6 into total number of patients in a day is 3,000, is 18,000 opportunities for making an error. Correct? Now, we also have a means of calculating how many of those gender or age were changed subsequently. And we believe it was changed because there was an error in the first time. So we went and calculated all those number of errors, and then we could get our sigma, because we know how many errors were made and how many opportunities for errors were there. So out of 18,000 opportunities, we had 6 errors, and there's a nice nomogram which gives you, if you have the total opportunities for error and the number of errors, you can calculate your sigma. So what we do is we give for each of our registration staff, we give their sigma level, because we know how many errors they have made and how many opportunities for errors are there. So what I'm trying to say is, once you've understood the concept, you need to improve your own knowledge. You need to apply it in your area of work. And believe me, it just grows. It enhances very well as you keep learning. And this learning doesn't stop. It's just a journey. It keeps going on. It doesn't mean I know everything of sigma. What I don't know of sigma is far more than what I know of sigma. So it's important that you apply that concept in your daily routine life.
Okay, thank you, sir.
I hope that helps.
Dr. Pallavi? Dr. Pallavi?
Good afternoon. Yes. So good afternoon, sir. As always, it was wonderful to listen to you and ma'am again. I have a question with regards to Six Sigma, sir. We have understood how to calculate that metric now, and I have a number with me. And I basically work from a setup where I have gotten this number manually, that is through an Excel sheet. I don't have an access to the URT. If we had a URT, we would have got a Six Sigma value which was being generated every day against each analyte. Now I don't have that access. So through the Excel for a particular analyte with the metric that I have, how am I supposed to adjust the QC run frequencies? And will this adjustment change every day, or can I have that sigma metric basis for QC run frequencies like for the next 1 month? How do I make use of this metric?
I think it's a very valid question that you have raised, because it's not only about understanding how to change the frequency based on the sigma. It's also the fact that from the regulatory point of view, or I would say the NABL point of view, are we allowed to change frequency? Can you hear me?
Yes, sir. Yes, sir.
Okay. So would NABL allow us to change frequency of QC based on sigma lower than what they have set in their
112, the latest guideline
in specifications?
Yes.
So I would think we should use the 112 specification as a basis. That should be the minimum. And if you have a sigma number that you have, you can certainly start manipulating the frequency based on your sigma. If your sigma is 10, I think Dr. Bernardas will be a better person to give you a frequency or the number of. So I would think I can run one level once a day if my sigma is 10. But that doesn't fit into NABL, isn't it?
Yes, sir. Yes, sir.
It will clearly put a non-conformance saying that you're not following 112.
Yes.
So
yes.
you need to follow 112, and over and above, you don't need to do any more numbers. You can run 3 levels once a day, and then say your sigma is 10.
Okay.
But the other side, if your sigma is less than 4,
yes.
any amount of QC will not give you the confidence. The only thing you need to do is if your TEA is set at a very high level, bring it down so that you allow yourself a little breathing space. See if your sigma goes up.
Yes.
If your sigma goes up, be happy with it. And if you really you want to improve, find out if it's the inaccuracy or the imprecision that is contributing to the low sigma.
Yes, sir. Yes.
If it's inaccuracy, my view is calibration is the concern. If it is imprecision, it's your QC material, your reagent material, and your instrument.
Okay, sir.
Of course, there are overlaps, but by and large, this is the approach, in my view. Dr. Barnali, I would like to hear from you.
Yes, as sir mentioned, we can actually in our day-to-day practice, we can actually define high frequency analyze in between and normal frequency and low frequency analyze, and based on that you can identify, like, you know, where the sigma levels more than 6. So then you don't need Unity real time or any other software. So like this thing you define more than 6 analytes which are in that range, and then 4 to 6 and less than 4. So as sir says, less than 4 you need the, like, you know, more and more frequency, and you need the more and more all the multi rules. So and for other analytes between 4 to 6, you maybe around 1/3s or 4s rule allowed, n is equal to 2 is acceptable. But then we can't actually ignore NABL 112. So if suppose you are running the workload is less and the parameter, then you can define n is equal to 2. But suppose it is the 24 hours lab and your workload is high, so you have to follow NABL 112 along with this. Based on sigma metrics, you can actually, like they say, between 4 to 6, 3.5s sigma. So don't take 3.5s because NABL SSR may not agree. So you can take 3s, which will be acceptable, and are one for the random error and one for the systematic error are 4s. So so that will, and 2s. So that will be easier to follow. Then you don't need all the, like, you know, multi rules if you are following cumulative mean and SD. And more than 6, actually with the rule based, you can actually decrease the rule. You don't need to, because most of the lab, they even follow 1 2s rule and all the multi rules. So there's a lot of like, you know, noise in the lab and unnecessary cost to the lab. So by following sigma, and you don't need any software. So for following sigma, you don't need PFR calculation and all, because if you get also that, you can't follow this because of the NABL rules and regulation. So take the NABL rule, as sir said, as a guidelines, and then you divide your analyze based on different frequency, like less than 4 sigma, 4 to 6 sigma, and more than 6 sigma, and you can customize your rules. That makes life simpler and easier.
Ma'am, and you can customize this for the next how many days, ma'am? Like, how do you decide that?
How many days? We take it as a quarterly.
Okay.
We take it as a quarterly because we tried monthly, then it gives a lot of errors comes from that calculations. So we take that as a sigma metrics. We calculation, we take that monitoring as a quarterly, because the moment less than 4, you can't even 1 month if you try to, like, you know, shift 4 to 6 is very difficult. So better to take as a quarterly monitoring, and then see, like, if you have improved through all your monitoring from less than 4, like, you know, 4 to 6 to more than 6.
Sure, ma'am. Thank you, ma'am.
Any more questions?
I see quite a few questions on the chat.
Yes, sir.
I think it would be time consuming. My suggestion is, can we connect on the email and we can discuss on the email, if that is.
Yes, sir. Yes, sir. That would be convenient.
If you've had email, because Avinash is saying that 6 sigma is allowing more error as more TEA is being allowed. That needs a bit of explanation. And,
okay, sir.
We need, Dr. Pranita is requiring an explanation of CLIA PT. There's a difference between CLIA PT and CLIA's recommendation for setting goals. So that's another discussion that we can have on the email. So if you can just connect us on the email, it would be good.
Sure, sir. We shall do that.
Yes, and how Sir said about the biological variation, I remember like 10 years back, I saw one of your presentation. So I took Sir example as a like, you know, to follow in my lab. Start with CLIA and then go to the biological variation, minimum, optimum, and desirable and optimum. So that's the best, Dr. Avinash, to follow. So then your error, like as you are mentioning initially, of course CLIA is broader range. You may feel like you are practicing better practice in your lab, but something to start and then you can shift. So I remember such presentation 10 years back, and we started from his presentation. We started our journey from that.
Thank you, ma'am.
Thank
If there are no questions, then we shall move on to the next session. Before that, I would like to thank Sir for the explicit session on quality and errors, perception of quality, errors, result reporting, and solutions to rectify these errors. Thank you, sir, for sparing your valuable time.
Thank you. Thank you for the opportunity.
Thank you, sir. We shall move on to the next session for today. By Dr. Katar Srinivas Rao, sir, on ethical considerations in GLP. Over to you, sir.
On this end.
You're audible, sir.
Hello.
Yes, sir.
Yeah. Is this picture visible to you?
Not yet, sir. Kindly share your slides, sir.
Right.
You may have to share your slides, sir.
Yep. I'm doing it.
Yes,
Is it
sir.
okay now?
No, sir. The slides are not visible, sir.
Slides are not visible. Okay. Share. ఇక్కడ వచ్చేస్తుంది మనకి వెంటనే. Give me a moment. It's happening.
Sure, sir. Yes, sir.
Can you see this now?
No, sir. You can reshare it again, sir. Try to reshare it again.
Right. No, can you guide me, please? Some technical hitch is happening over here.
Yes, sir. Yes, sir.
Sir, you can just click on that share button, sir. There is one arrow which is pointing upwards.
Right, okay.
You just click on that, sir.
Right.
Now you will get the option that is share the screen, or you can share even the PowerPoint. I suggest you go for sharing the screen itself, sir, so that it becomes a little easy.
Screen share.
Yes, sir.
Right, it's done. Okay, and now I have options of entire screen or window or Chrome tab.
Yes, sir. Go for entire screen, sir, because that will be easier. If we then choose that one, that has to again get loaded onto that. Select the entire screen, sir.
Right.
Yes, sir.
Is it coming up now?
Yes, sir. Now we are now visualizing your entire screen, sir. Now you can go ahead with the slide show.
Can you see it now?
Yes, sir. Yes, sir. We are seeing it now.
Right. Okay. Good afternoon, everybody. It's right at the outset. Let me thank Dr. Barnali Das from Mumbai and then Dr. Sujay Prasad from Bengaluru. Have done my job very, very easy. They have sensitized all the audience regarding the various aspects of pre-analytical, analytical, and then post-analytical stages of laboratory testing. And thanks again to Sri Devraj Arts Academy of Higher Education and Research for putting me before you people. I sincerely express my gratitude to Dr. P. Vijayalakshmi and Dr. P. Sishai, who are my teachers in post-graduation days, and to Dr. C.S. Bhaskaran and Dr. Ravi, neurovirologist, Dr. Savitra Sharma from LV Prasad Institute, Dr. S.P. Tyagarajan, who is working at PGIBMS Chennai, Dr. Suniti Solomon, who was pioneer in HIV work in India, Dr. Malini Kapoor, who is there in Delhi, and Dr. Anupama from Chennai. These people have a lot of impact on my academic growth. It's my responsibility to express my gratitude to all these personalities. Now, my topic is ethics, bioethics in regarding laboratories. So what ethics is all about? Simple thought is, it is a set of principles of right conduct. If you understand this sentence, this applies to every walk of life, not only for the laboratory, but also to every walk of life of a human being. Now, we got to be very, very cautious when we come to ethics in the laboratory. The evolution of this bioethics or medical ethics or ethics in the laboratory started with the Nuremberg Code in 1947, Declaration of Geneva of 1948, Declaration of Helsinki in 1964, Belmont Report of 1978. Out of all these things, the cornerstone will be the Belmont Report. Why Belmont Report is cornerstone for this bioethics? It's an amalgam of Declaration of Helsinki and then Declaration of Geneva, wherein the principles of bioethics are incorporated into 3 principles only, but for convenience sake, I included number 4 also here. The ethical principles and guidelines are clearly demarcated in Belmont Report. The 4 core principles, I told you very clearly that there are only 3 from the Belmont Report, but I added 1 more, only to be clear of another factor. Respect for persons, it should be maintained all over the clinical laboratory, either in the pre-analytical or analytical or post-analytical stage. That's what we call autonomy. And then do only good, that is beneficence in all the phases of the laboratory. And then non-maleficence, do no harm. Actually, the beneficence include non-maleficence as well. But for convenience, I divided this. And then the last principle on which the bioethics revolve around is equitable distribution of risks and benefits. Now, in this definition of justice, equitable distribution of risks and benefit, the benefits, the maximum benefits must be there from the laboratory side. Otherwise, it will be a big problem. And different organizations and different countries and many professional bodies have their own policies and guidelines. But International Organization for Standardization came up with clear-cut principles and implementation and then guidelines, what do you call the procedures for bioethics in the laboratories, in the medical laboratories and research laboratories as well. And ISO 15189 2012 section 4113 says the laboratory activities should not lower the confidence in the competence, impartiality, or judgment of the laboratory. So whatever the activity that we take up in the lab, what we take up, they must hold the competence of the laboratory personnel. And then there should be a uniform law of impartiality to everybody, everyone, and every sample. And the judgment must be very, very equal to all the samples, all the personnel over there. And then all throughout the process, when a sample is submitted to the laboratory, the confidentiality of information must be maintained. This is utmost important one. And then the other aspect of ISO 4113 of 2012 15189 says it should be free from undue commercial or financial pressures. The management or the directors or the personnel involved in the laboratory or in the research setup must be free from commercial and financial pressures. Otherwise, these issues will totally damage the outcome of the reports, outcome of the research frameworks. And then appropriate procedures ought to be involved in treating all the human samples, including the storage of samples if it is needed later on. What are the different ethical issues in the pre-analytical phase? We all know that the sample will undergo 3 phases in the laboratory, either in the clinical laboratory or in the research laboratory, either biochemical or pathological or microbiological laboratory. I'm not confining these ethical issues to microbiology. I'm a microbiologist. I do not confine this. Over the last 25, 26 years in the teaching profession that I'm there in government medical colleges across Andhra Pradesh, some issues have been raised, some issues have been clarified, and I'm putting all those things right now here. The ethical issues in the pre-analytical phase include the identification of the patient is number one, proper identification. If the patient is not identified properly, the entire process goes bizarre, like collection of the sample, the identification, labeling of the sample, and appropriate handling of the sample. So when you don't identify the patient properly, it becomes a huge risk for each and every person in the laboratory. It's not that a laboratory person alone is responsible for ethical issues. It's not that way. The entire laboratory team work is mandatorily involved in ethical issues. For example, we do not have a formal teaching of medical ethics in medical schools or post-graduation or in research institutes. As such, the local bodies of Indian Medical Association, the State Medical Councils and NMC must take it to the task that this biomedical ethics must be part of the curriculum of the undergraduate program as well, right from the first day of the program. Now a CPMB program is being instituted all over the medical colleges in India, but that's becoming a mere eyewash formality. It should not be that way. A proper, thorough understanding of the biomedical ethics must be included. As such, the laboratory medicine training programs do not involve these biomedical issues in detail. My presentation today will not be a detailed or comprehensive one. It will be a little supplementary to whatever that's happening over the professional bodies, guidelines, suggestions and all. The maintenance of the ethical standards in the pre-analytical phase will be a joint effort by the laboratory, by the healthcare provider, by the researcher, by the phlebotomist, or the person whoever collects a sample. So the proper identification of the subject must be the prior target, and then collection of the sample appropriately, appropriate identification, and then identification of the sample, processing of the sample. Okay, when there are 3 principles, as I told you from the Belmont report, that respect for persons, that is autonomy, beneficence, and then justice. All these 3 principles can be applied in pre-analytical phase. How to understand these? Confidentiality. This is by far the most important property or trait that we should be involved with ethical issues. Confidentiality, as far as automated laboratories is concerned, due to the use of barcodes and then all those high-end laboratories, confidentiality is totally maintained. But in small laboratories, confidentiality is a big challenge. So we got to be very, very cautious of that. So when we Hello, is it audible?
Yes, sir. Yes, sir.
Okay, when we talk about these the three principles with respect to pre-analytical phase, respect for persons, the autonomy must be thought of very carefully. Once the person walks into the laboratory, either biochemistry or pathology or microbiology, the person will come with a requisition in private practice or in government hospital. What are all the tests that are needed? So it's not mandatory that we should question the patient, why is it you are having all these tests? So with that informed consent or requisition from the clinician, the patient walks in, the subject walks into the laboratory. So we can just allow the patient to give the sample, whatever the sample that's needed. We can comfortably make him sit, either blood sample or urine sample, whatever the sample that's asked, we can collect the sample and do the processing. But this consent or requisition may be a little problem with respect to elderly people or mentally abnormal people or patients suffering from critical illnesses. Then who is allowed to consent on their behalf? So we have to devise the laboratory, either the teaching institute or the private laboratory has to design their own set of procedures appropriately regarding this setup. For children who are generally cannot take up a decision that they need this test or they don't need that test, it is the parents who bring the child with appropriate requisition and all. So that's not a problem. But when a comatose patient comes, who should give a consent on their behalf? So the legal issues, all these things must be clearly displayed in the laboratory setup, either in the teaching institute or in the private setup. So once the patient sample is brought, or once the patient is brought to the laboratory, then we collect the sample. The beneficence aspect will come. The autonomy will be maintained here now, and the beneficence aspect will come, the second principle. As far as this principle is concerned, we should give maximum benefits to the person or the sample, and then less harm or no harm to the person, a patient or subject or the sample. How can this be achieved? This beneficence, the second principle of biomedical ethics, can be achieved by regular, refreshing training programs to the laboratory personnel, every laboratory personnel, and then following universal precautions and adapting standard operating procedures. This is the point where most of the laboratory personnel in teaching institutes are lacking. The limitations are there for following universal precautions, and then standard operating procedures are not being followed, not written clearly as well. And then they reluctantly go for training programs, for refreshing or for induction training programs. That is where the problems come in. Even if they go for training programs, that will be a little eyewash only. And once they go back from the training programs, the implementation of the knowledge from the training programs will not be achieved. So as such, they'll be regularly facing a lot of ethical issues. Once the patient comes in, the patient must not have any discomfort in submitting the sample, or the person who is there in the sample collection process should be trained enough so that least amount of discomfort is felt by the patient. Coming on to the third principle of biomedical ethics in pre-analytical phase, that's about justice. The laboratory, either teaching institute or a private laboratory or a research institute, they should have a wide variety of laboratory tests at a very, very reasonable cost. Very, very reasonable cost. And then laboratory should evaluate the need to introduce newer tests as and when the need arises. and then whenever there is an opportunity to discontinue the older tests as well, when better tests are available. And here the biggest problem is no preference should be given. That is, preference should not be given to anybody to facilitate or enhance or expedite the collection process of a particular patient over other patients. Suppose the lab sample collector knows a person, known person comes to him, he should not keep other people waiting in the laboratory. This is the point where the ethical issues become huge and enormous on the laboratory aspect. So the 3 principles in the pre-analytical phase must be carefully applied in these respects. About the ethical issues that we face regularly in analytical phase are confidentiality. Okay, now, as I told you earlier, in automated laboratories, maintaining confidentiality is not a problem. But in small setups or point of care testing, or when we go to the patient and then we do some rapid test, then the anonymity or the respect for the patient or the confidentiality will be gone. So we got to be very, very careful over there. When you go for a point of care testing to the patient bedside and do the test, it is mandatory that we have to have a standard operative procedure, that we should not disclose the report to the patient or to the attendants, only to the clinician, in charge clinician there, and then come back. Otherwise, you announce the report to the patients. If the clinician is busy over there, that results into a lot of troubles. A lot of ethical issues will be raised over there. So in small laboratories, the maintenance of confidentiality or point of care testing, maintenance of confidentiality is a huge problem. In analytical phase, the autonomy can be easily maintained because automated laboratories, it's very, very easy. But point of care testing, autonomy cannot be maintained. So standard operating procedures must be maintained very diligently, very, very diligently. And then beneficence regarding the 3rd principle in the analytical phase, we got to give the best possible analytical result. The best possible analytical result is the product of the teachings, the immense lucid presentations by Dr. Barnali Das and Dr. Sujay Prasad, earlier speakers. Okay, what they taught is, in total, is a rigorous quality assurance program only. Once you have that rigorous quality assurance program where your comfort is not taken care, only the comfort to the laboratory, the accreditation to the laboratory is thought of. The rigorous quality assurance program is not a new one. It includes a lot of things. It includes proficiency testing. It includes quality control testing. It includes the laboratory accreditation also. So the rigorous quality assurance program, if we start focusing on this, everything will...
Yeah. Yeah, I'm fine.
Everything will fall into place. There is a saying in the analytical phase regarding the reporting or processing and all, that a wrong result is worse than no result, or no result is better than a wrong result. This will happen because when the quality assurance programs are not being implemented in the laboratories, either the quality control programs, either the internal quality or external quality, and then proficiency testing or accreditation process are not there, these wrong results are likely to spring very regularly. Then if you don't identify these things, then the entire quality system goes bizarre. When entire quality system goes bizarre, you don't know what kind of report is being generated, what kind of report you're signing, what kind of report is being issued to the client. And these things are to be borne in mind very, very carefully. So good laboratory practices are mandatory. That's the reason ICMR in 2017 has come up with good clinical laboratory practices for laboratories as well as research units as far as hospitals. We got to have all these copies so that we need to expand our horizons of good laboratory practices very regularly. Sometimes tricky situations will happen. A CSF sample will come to us, or a pleural fluid sample will come to us, either in the biochemistry or in the pathology or microbiology, whatever the investigation that they need. If the CSF sample is mixed with blood, we should have a standard operating SOP for that as well. We should not refuse the sample saying that the CSF is blood tinged, or blood is present, or hematoma is present, or blood clot is present in the CSF sample. We cannot process it. We cannot send it back that way, because we cannot collect the sample again by lumbar puncture. It's very difficult to obtain sample. So we have to have our own SOPs in such kind of situations during the analytical phase. And regarding the third principle in analytical phase is justice. Now, based on gender, based on age, based on racial origin, you start processing the samples in the laboratory, it will be totally discrimination, stigma, and that's not the ethical. I mean, we are likely to face a lot of ethical issues, bioethical issues. It's a huge problem over there in general hospital setup, where we have wide range of patients and wide range of samples and all. It's very, very difficult. But once you start establishing a rigorous quality assurance program, all these issues will dissipate, will just disappear. So the primary objective of a clinical laboratory or a research laboratory must be to have rigorous implementation of quality assurance program. A priority must be analyzed for certain samples during analytical phase. Suppose a CSF sample of a child comes, of an infant of a 2 days duration comes, that must be prioritized. Not that a special attention should be paid with respect to testing and all, but prioritize those kind of samples. At risk or highly risk samples must be prioritized. And then we should develop our own SOPs regarding that at risk or prioritizing samples of that kind. And then next, what I want you to have is during the post-analytical phase, the ethical issues will be related to reporting, interpretation, specimen storage, data access, and other key. One more key aspect is that this what will happen, who will hold the responsibility of specimen storage and all. For this post-analytical phase, again, it is a laboratory person who is trained sufficiently and adequately must be involved in the reporting and interpreting the results. Reporting is not just enough. Interpreting the report is also enough. I'll just give my personal example. I am a consultant for a RT-PCR laboratory in my hometown. During the pandemic, we were analyzing the samples. We were just understanding the samples. The positive control was very good. Internal control was very, very good. NC and PCs were running very, very good. And we were talking about, the two consultants were discussing about the positive control over there. A lab technician has come who has loaded the PCR machine, and then he heard the discussion, and he was interested in a particular sample, and we were discussing about the positive control. He went out and said that the particular patient was positive. I mean, these kind of things ought to be avoided in the laboratory. Hearsays and overhearing, all these kind of things. So the request forms must be very, very good. Going on to this ethical issues in a post-analytical phase, that's where I think it's got disconnected, I believe.
Yes, sir. Yes, sir.
Yes, these ethics, why is it bioethics are so important? Decisions about diagnosis, prognosis, and treatment are based only on the results or reports that we give out of the laboratory. So the proper interpretation of the laboratory test must be done in the laboratory, and otherwise the erroneous results will cause irreversible harm to the patients or the research subjects. Ethics is also applied to the behavior of the entire laboratory community. The entire professional approach must be there in the laboratory by all the people, all the personnel. The professionalism is not a big issue. It's just dressing appropriately. That's it. If a laboratory coat or apron is soiled, change it to a clean one. And then while we are doing in the lab testing and all, should not use the cell phones and all, because I have seen in government setup many of the laboratory technicians busy bending over their shoulders and then talking over the phones and then carrying out the tests. All these things can be really avoided. This is what, if these bioethics is not followed, we will be struggling at one end, and legal ethics and ethical issues will be arising, will be springing up very, very regularly at very, very regular intervals, and there'll be clear-cut tussle or altercations between the patients, between the laboratory individuals, among the laboratory individuals and all. So we got to be very, very cautious about these things. Code of ethics is we got to maintain strict confidentiality of the patient information anywhere, everywhere, and the dignity and the privacy of the patients must be maintained at any cost. Let us not take back the details of the patient to the home or to the workplace and all. So we got to stick to the information. We got to paste the information right in the laboratory, and we should be accountable for the quality and integrity of the clinical laboratory services. This is the aspect, the accountability of the laboratory personnel is really needed, is a need of the hour in establishing the quality assurance programs, rigorous assurance programs in the biomedical ethics or bioethics in the laboratories. And then we got to treat the patients and colleagues with respect, care, and thoughtfulness. This is where Dr. Sujay Prasad was saying, the communication. Once we establish this communication by treating patients and colleagues in a uniform way, everything will fall into place. And then the duties must be done in very precise, accurate way and in timely, responsible manners. And then the patient information must be safeguarded throughout the life. And then we got to use the laboratory services very, very prudently. Let's not misuse the laboratory services or resources. Right to privacy is very, very confidential. We got to think about that. What does this confidentiality mean exactly? We have a lot of patients. Suppose a patient of A, information is there with us. We should not share that information with B, even if the patient A and B are very, very close friends. So we should be very, very confidential. It's important to keep all client patient information privacy, and then securing all the records and logbooks and restricting access to testing areas. And then people often violate ethics, not because they mean to, but they're just a little careless, complacency. As a matter of fact, they sometimes act with good intentions only and excitedly. So they want to help by declaring the results and all. So we should not do that. In laboratory, we should be very, very balanced, very reasonable, very rational, and very, very accountable. Now here you can see a cartoon which is self-explanatory. The person is asking about the results, and the clinician says yes, has put them on website, which is to be avoided. We got to be very, very cautious. What is the information that is so confidential? Every information, whatever the information that the patient provides us, or the doctor or the clinician supplies us, is confidential and must remain confidential. And entire results, whatever the results we have, they must be very, very maintained confidentially. At work, the medical records are very, very confidential. The computer screens are to be protected. The timeout functionalities must be maintained. Patient information should never be discussed with friends or relatives in a social setting. This is one other situation, because during the pandemic, it was known that the client will not know the result first. the attendants, the neighbors, everybody will know that the patient is, the client or the subject is positive for COVID. These things are avoidable, but we got to maintain, we got to reassure ourselves in maintaining that. At home also, we should not disclose or discuss any patient information, either with the media or with anybody. How do we apply ethics in the laboratory testing? In the laboratory, we apply bioethics by using only kits approved for use in the country, ensuring quality outputs, following SOPs. If the test procedure calls for about 20 minutes, then there is no shortcut. So, I mean, a lot of people in government setup, they take half the sample, half the reagents, and they cut short the time as well, the incubation time as well. And this is not warranted. This is not necessary at all. Wait the full time before recording and reporting of the results. And then keeping the supplies and kits in safekeeping, handling human tissues or organs or cells in research with consent and human dignity. If you have questions, ask. We mean a lot of people are there now. Right now today, I had really a big academic feast for me from Das from Mumbai, and then from Sujay Prasad from Bangalore. We can start asking questions. And what is the duty to the patient? We are accountable for anything that happens to the patient. So the key messages are we got to remind ourselves about the code of conduct and ensure that we do the right thing only. And then ethical issues are very, very hard to deal with because they create a lot of dilemmas. So if you are accountable for yourself, if you are rational, if you are reasonable, if you are logical, then implementing the biomedical ethics or ethical issues in the laboratory is simple cakewalk. But thing is, most of the time, we create a lot of dilemmas in each walk of life, and we apply that dilemmas to the laboratory as well, so that everything goes bizarre. So we got to be very, very careful, very, very careful. And this is a little cartoon of two persons. One person went for a blood test and got cloned by a mistake. This is something funny. These kind of issues are happening not in high-end laboratories, not where automated laboratories, not where accredited laboratories are there, not where proficiency testing is there, not where quality control systems are there, not where quality assurance programs are rigorously followed. When these things happen only in setups where quality assurance programs are not being maintained at all. And my acknowledgements are due to IJMM Desikan 2011 article, and then ICMR GCLP, WHO GCLP, and then International Federation of Clinical Chemistry and Laboratory Medicine, and then a huge thanks and bow of thanks to Devraj Earls Academy of Higher Education and Research, and a big thanks from my side. I think I'm in time.
Yes, sir.
Once again, my profuse thanks to the earlier speakers who made my job very, very easy, very simple, and to Devraj Earls Academy of Higher Education and Research. Thank you. Thank you, one and all.
Thank you so much, sir. Any queries or questions from the participants? You can go ahead with it. Any questions? Anybody? I'm just checking. So there's a question in the chat box from Dr. Sheila. For vulnerable populations, can we take it from LAR?
Come again? I didn't get you.
For vulnerable populations, can we take it from LAR?
Yes. I mean, that again depends on the specific nature of the vulnerable group, and then the management of the vulnerable group or NGO who are doing it, it needs a lot of consents. It needs a lot of mutual agreements as well.
Yes, sir. Any more questions? Any questions? If not, then we can thank Sir for the explicit session on ethics and GLP, principles of right conduct, ethical issues in pre-analytical, analytical, and post-analytical phase, and confidentiality. Thank you so much, sir, for sparing your prize time.
My pleasure.
We shall now move on to the vote of thanks by Dr. Shilpa, Assistant Professor from Department of Pathology. Over to you, Shilpa.
Avira, ma'am? No.
Good afternoon, everyone. I take this opportunity to propose vote of thanks on behalf of Research and Innovation, SDUA HER, and Departments of Biochemistry, Pathology, and Microbiology of Sri Devaraja's Medical College. First and foremost, we pay respect to our late founder president, Sri R.L. Jalapa. I would like to thank our patrons of Sri Devaraja's Education Trust, Honorable President and Chancellor, Sri G.H. Nagaraja, Honorable Vice President, Sri J. Rajendra, Honorable Secretary, Hanmant Raju, KG, Honorable Pro-Chancellor, Dr. C.V. Raghuveer, Honorable Vice Chancellor, Dr. Pradeep Kumar Ji, Registrar, Dr. D.V.L.N. Prasad, Dean Faculty of Medicine and Principal, Dr. Sriramulu P.N., and Medical Superintendent, Dr. Sheila S.R. I also thank Dr. Shashidhar K.N., Professor and Head Department of Biochemistry and also Vice Principal SDUMC, whose motivation has been pivotal in conduct of this workshop. I also extend my sincere thanks to Dr. S.M. Azim Mohiddin, Director R&I, for his undaunting support and encouragement in conducting various events of R&I. We thank the professors and heads of the Department of Pathology, Dr. Kalyani R. and Microbiology, Dr. Arvindan, for their constant support. We also thank the distinguished luminaries for accepting our invitation as speaker and delivering insightful presentation. Thank you, Dr. Barnali Das ma'am, Dr. Sujay Prasad sir, and Dr. Srinivas Rao sir. We thank all the participants of today's events for making it a grand success. Thank you one and all.
I request the participants to on their video for the group photo. On your video for the group photo.
I request all the participants to on their video so that we can take a photo. Yes. Thank you everyone.